Yes,
Okay, good.
I got confirmation.
So you can actually start the streaming.
It's starting right now.
Okay. And then
You're on. We're on.
you can put on um the poster, the welcome poster.
Yes, that's what I'm working on now. I had to email it to myself. Just I had it on.
Dr. Neuroso, is this the link I will use for all days, or am I in the wrong link?
Hi, Becky.
Hello.
Uh, Hi, Sarah.
Hi.
So, Becky, are you
Hi,
ready to
Sandy.
kick off?
Morning, girl. I'm ready anytime
Nice to
you
see you,
are.
Sarah.
Okay, great.
You look
Yes, it
sleepy.
is. I'm in an airport, but
Oh my goodness. Well, thank you for joining. Where are you going?
I'm going to Salt Lake City, Utah. Yeah, fun
So,
time.
You're probably excited.
Yeah.
so Schneider, it looks like you're having challenges putting up the poster. So maybe we'll just start. Okay. So I'm
Yes.
clicking on start webinar.
Yes. I mean, I can share the poster, but it would be me sharing my screen.
Okay, so I'm starting webinar now.
Okay.
And then we'll have to spotlight um, Becky. Becky is the one that will introduce. Welcome, everyone.
Yes.
So as soon as we go live, I start. Good morning. Welcome, everybody. We're thrilled to have you here. My name is Becky Rock, and I am pleased to be one of the co-moderators today for the Bloodless Medicine and Surgery Society 10th Annual Scientific Conference. We're thrilled to have you here. We wanted to let everybody know that this is an international and multidisciplinary society of experts in blood transfusion avoidance who promote bloodless care with the aims of improving clinical outcomes and protecting patients' rights. We're very excited about the theme of this year, which is Medical Informatics Advancing Bloodless Medicine. We've chosen an excellent panel of speakers today to get things started and to begin our learning. So please remember that the conference is a 3-day event from today through Friday, and it's going to start at the same time every morning. That's at 7 a.m. Eastern time in North America, 12 noon, that's in Central Africa time, or sorry, 12 o'clock noon GMT, 1 p.m. in Western Africa, and 8 p.m. in Malaysian time. So whatever time it is for you, thank you for joining us. I'm pleased to introduce my co-moderator for today, who is the esteemed Dr. Neil Bloomberg, Professor of Pathology and Laboratory Medicine, Director in the Transfusion Medicine Unit, Blood Bank, and Stem Cell Storage Facility at the University of Rochester Medical Center in Rochester, New York, United States. Welcome, Dr. Bloomberg.
Thank you, Becky. The conference chair is Jonathan Waters, who unfortunately cannot be with us today, this morning anyway. And so what we're going to do is have Becky give her a brief welcome on Dr. Waters' behalf, and then we'll get on with the presentations.
It appears that you froze up a little bit there. Dr. Bloomberg, your screen froze and we missed your words.
Oh, I'm sorry. Can you hear me now?
Yeah, we can.
This is my home Wi-Fi, so it may be less reliable. So I'll repeat what I said just in case uh, nobody heard it. Dr. Jonathan Waters, who many of you know, who is the longtime director of anesthesia for Women's and McGee Hospital in Pittsburgh. He's an anesthesiologist, particularly has had an interest in cell salvage and many other techniques that are important in the area of bloodless medicine and surgery. And Dr. Waters, unfortunately, while he would very much like to be here, could not due to a family emergency in his life. And so we're going to proceed without him, and hopefully he'll be able to join us at some point. So did that all go through?
Absolutely. Yeah, thank
Okay.
you.
So I think at this point, maybe we could just move to the next part of the presentation. Becky, I think we're going to have a brief presentation from our president, Dr. Usuro.
Thank you, Dr. Blomberg. I would defer to Becky first as the co-chair. She is representing Dr. Waters. So Becky.
Sure. Thank you very much. I'll just do a quick few words. So it's my pleasure. We regret that Dr. Jonathan Waters wasn't able to join us, but it's my pleasure to welcome everyone on behalf of him and the entire organizing committee of the Bloodless Medicine and Surgery Society Annual Conference. Planning has been underway for this conference since the beginning of the year with all of you, all attendees, volunteers, and fellow speakers in mind. Our goal was to bring together for you some of the world's most renowned experts on topics relevant to bloodless medicine and surgery and patient blood management. As organizers of this conference, we all have our reasons for being here, and we trust that you too have good reason to take time to be here too. You might be practicing in medicine, in surgery, nursing, laboratory, some other field within healthcare. You might be an expert, or you might be very new to this subject. You might be a healthcare leader or an industry representative. Or you might be here because through and through, you are an advocate, a person with passion and determination to advance the cause of bloodless healthcare and PBM because it's ethical, it's just, and it's superior healthcare we all deserve. So thank you for being here, and we hope you all enjoy the full conference. So at this time, I would like to pass it back to Dr. Nathaniel Usuro to deliver the President's address.
Thank you, Becky. Our distinguished BMSS members, speakers, moderators, attendees, and everyone here. It is my privilege to welcome all to the 10th Annual Scientific Conference of the Bloodless Medicine and Surgery Society. Yes, we started this society in 2015. And so today we have grown from a regional society to an international society. Actually, from our very first conference, which we held in Calabar, Nigeria, in the University of Calabar, we have always maintained the multidisciplinary outlook and an international outlook as well. We had speakers and delegates for that first meeting of 2015 from the West African sub-region, from North America, Europe, and Asia. And for the next 5 years, we're holding physical meetings until the pandemic came in 2020. That is when we went online. It was a blessing in disguise because it now made it possible for people all over the world to join without having to travel. And the attendance has increased seriously, and the membership too. So at the last count, virtually all continents of the world except Antarctica were represented here at this meeting, and more than 50 countries worldwide. So we have maintained the online format till today, since our membership and participation is growing all over the world. We have also maintained our focus, as Becky said, on improving clinical outcomes and protecting patients' rights through bloodless medicine and surgery. As a matter of fact, the Bloodless Medicine and Surgery Society is currently the only professional society in the world that focuses on evidence-based techniques and the scientific basis for total avoidance of blood transfusion. So I welcome you all very much to this 10th Annual Scientific Conference of the Bloodless Medicine and Surgery Society. The theme is Medical Informatics, Advancing Bloodless Medicine. And we have a lot to gather from this meeting, from the experts who have so kindly donated their time and their resources to make sure that we gain a lot of knowledge at this meeting. So let me stop here and once again welcome everyone to this meeting. And before I end, let me thank very much all the speakers and all the moderators, panelists, and also the members of the planning committee who have worked so hard to get this meeting going. Welcome everyone. Enjoy the next couple of days at BMSS 2024. Thank you.
Thanks very much, Dr. Usoro. So this morning we're going to have four interested talks by seasoned investigators and clinicians, and then we'll have an oral abstract session. But I think Becky is going to tell us some of the ground rules for this morning. Becky, please.
All right, thank you. Yes, the rules of engagement. So just wanted to remind everyone that as you're listening to the speakers today, you should place your questions in the Q&A section of your Zoom screen. You should see the little icon by which you can present that. Some of your questions might be answered during the presentation, but we hope as moderators that we'll bring some of those questions back to share them with everyone as well. Please be sure that you minimize any chats or distractions that could take away from our speakers. We want to give them our great attention. And please know too that this program is being live streamed on the Bloodless Medicine and Surgery Society YouTube channel. So if you have any difficulty with the Zoom today, you can always go to the YouTube channel to watch the events today. We will put the link into the chat box, but you can also just do a simple Google search of Bloodless Medicine and Surgery Society inside of YouTube. And just finally, please bring your great questions. All of these speakers have prepared excellent presentations for you. They're really looking for your engagement. So please ask some great questions to get some great discussion. So without further ado, it's my honor to be able to introduce the very first keynote address for the conference entitled Evidence from Big Data and Machine Learning Regarding Transfusion Outcomes. And our speaker is the esteemed Dr. Kevin Trentino, who is a senior researcher at the Medical School, University of Western Australia in Perth. So Dr. Trentino is a postdoctoral health services researcher and a senior analyst supporting Western Australia hospitals and health service. His expertise in data and statistical methods to drive patient safety and quality, and his research has included patient blood management, digital health outcomes, clinical prediction models, and health economics. Kevin is also a member of the World Health Organization's expert working group for the implementation of patient blood management. Welcome, Dr. Trentino.
Thank you very much. Thanks, Becky. Thank you for that kind introduction. I'll share my slides, see if I can get this to work. Okay. Can you see the slides clearly there?
Yep.
Fantastic. So I would like to thank Becky for that kind introduction. Also thank Professor Waters, Neil Blumberg, and Professor Usoro, and obviously the BMSS 2024 Conference Committee for this invitation to present. So I'm going to talk on a topic which I think is very important and also very interesting and obviously highly relevant, and that is evidence from big data and machine learning regarding transfusion outcomes. And in doing so, what we're going to do is address the following questions. So the first question we're going to look at in this presentation is, what is big data? The second question we'll look at is, what do statistical and machine learning models teach us about transfusion outcomes? And the third question we'll look at is, what do we learn from RCTs, randomized control trials, and observational data regarding causation, specifically looking at transfusion outcomes? So let's go to our first question. What is big data? Well, we're witnessing a data revolution. And this was a headline back in 2017 from The Economist. And the headline read that the world's most valuable resource is no longer oil, but data. And it really emphasized how data has become crucial for driving innovation, informing decision-making across a variety of industries and sectors, but this is highly relevant to healthcare. And what it's fed is the growth of this new role, the data scientist. So the data scientist was previously someone who was unknown, maybe even non-existent. Now this is gone from being unknown. They've gone from being unknown to considered one of the sexiest jobs. So that's quite a big turnaround in a short period of time. And one buzzword from the data revolution is big data. I'm sure you hear the term being used frequently. But what actually is big data? It's actually surprisingly difficult to define. And it's one of those definitions that is context dependent, meaning you ask different people, they'll give you different answers. You ask over a period of time, and the definition evolves. So I'll attempt to give you what I think is a good definition of big data, and it involves what is commonly described as the 3 V's. So the first is volume. And I'm sure a lot of people, when they picture big data, they think of volume. So they think of lots and lots of data, enormous quantities of data. But there's other things to think about with big data. There's things like velocity. And what we're talking about with velocity is data that's created in real time, and maybe even data that comes at us at a far higher frequency than ever before. And then thirdly, we've got variety. So when we're talking about big data, we're talking about data that's structured in traditional ways, but also data that's semi-structured and unstructured. I'd like to go through these 3 points again, but use an example that I think will highlight it. And we're going to talk about the difference between large data and big data. So when we talk about large data, well, large data can be millions and millions of data points stored in structured databases. It can be updated frequently. It can even be live, and it typically consists of numbers and text stored in rows and columns, and that's what we call tabular data. So large amount of data is not really big data, though we could say that big data is large. It's huge in volume. Let's talk about velocity, because velocity highlights quite a lot. So velocity, we're talking about high frequency data, and we're even more than ever before collecting data from things like sensors. So for example, we've got lots of patients that will walk around with heart rate monitors or fitness trackers. You think of patients connected to ECG monitors, and we're collecting data that's continuous, and it's recorded at very high velocity. So if you think, for example, of high frequency physiological data in the form of like waveforms, so with our ECG data, that's typically sampled at heart rates of, I don't know, 250 to 1,000 hertz. So when we're talking about that frequency, we're talking about 250 to 1,000 data points per second. And that can't be stored in traditional ways, as you can imagine. So you get a sense for what velocity means. When we're talking about a variety of data, we're talking about data that is typically structured, like our patient demographic data, diagnoses data, treatment data, our medication data that we store in that tabular form, rows and columns. But we're also talking about having unstructured data, like images from X-rays, MRIs, CT scans, which require specialized software for analysis, or even sensor data, as we've got in just the image above there in the middle. As we mentioned, that's high frequency data that comes in the form of waveforms. Or how do you store waveforms? You don't store those in traditional tabular databases like SQL databases. So I hope this gives you a feel for the difference between large data and big data. Now, there's surprisingly very little published in transfusion research or even transfusion avoidance on making use of big data. So this is an area where there's a big need, And I think we're going to see a lot of research come out in that space. I'm certainly excited with the work we're doing in our health service. We've got access to a lot of high frequency data, and we're starting to look at some of this. So I think we'll see lots of exciting research come out in that area, but at the moment there isn't a lot there. There's a lot published with huge volumes of data, and that's what I'll focus on in this presentation. So let's go on to our second question. What do statistical and machine learning models teach us about transfusion outcomes? But if okay with you, I think it'd be good if we take a step back and maybe ask a more simple question, like why do we even run models in the first place? Why are we running statistical or machine learning models? Well, the reason why we're running them is because we assume there's some relationship between an outcome, here given by the variable y, and other factors given by those variables of x, x1, x2 to xp. Now, I've included an image here of an excellent textbook if you're interested in more detailed information. But there are two main, in very basic terms, there are two main reasons why we wish to run these models. The first is prediction, or one of the reasons is prediction. Now, when we're running a prediction model, the y value represents whatever we're trying to predict, and that f, that function of x, really can be a black box in the sense that we're not typically concerned with what that looks like. We're not concerned with the exact form of it. We're really just interested in getting the most accurate prediction we can for the value y. Now, this is very common in machine learning studies, and much has been published on this. And so the examples I've put there at the bottom of the slide, you'll see two research papers there. These are examples that I've been involved with that use statistical and machine learning models to predict red cell transfusion. What these studies show is that red cell transfusion is fairly predictable, can be predicted with fairly good accuracy. Now, we're not going to focus on this, though, and the reason why we're not focusing on this is because we're keenly interested in what evidence from these large data studies teaches us about transfusion outcomes. And that's why the second reason why we run these models is so important. This is really what we're focusing on in this presentation. So with inference, we're interested in understanding the way that the y variable is affected by the values of x. We're wishing to get, our goal isn't to make a prediction as such. We're wishing to understand better the relationship between y and all those variables that are associated with y, those x variables. More specifically, we're trying to understand how y changes as a function of our x1, x2 through to xp. And so we can't afford for that to be treated as a black box. We're trying to understand its exact form because we want to answer questions like which predictors are associated with the outcome, what is the relationship between the response and each variable in the model, how do these interact with each other, what are some of the mediator effects, and some of these questions. Now, this is very important when we're trying to answer the question, what is the relationship between red cell transfusion and patient outcomes? So let's focus in on that now. Bearing in mind, we're trying to look at large studies here that have been published. So back in 2013, Hopewell and colleagues published this systematic review. And these studies were comparing transfused to non-transfused patients over a 5-year period. Now, they specifically were looking at what they called large studies. Now, you've got to remember this was between 2006 and 2010. And a large study then was defined as 1,000 patients. So if come back to what we said, these definitions change over time, obviously. And they had, they pulled the results of 32 different studies. And what they found was a consistent adverse effect of red cell transfusion on mortality. This is data from 2006 to 2010. In trying to find updated data, we struggled a little bit. So we thought for this presentation, we would conduct our own updated review. So applying a methodology very similar to that 2013 study by Hopewell and colleagues, we looked at large studies examining transfusion and outcomes, but instead of going for studies with 1,000 patients, we decided to only include studies with over 10,000 patients. So now we're looking at 10 times the amount of the previous study. And we looked at the most recent 5-year period. Now, I'm not sure how much you can see from this table here. Hopefully it's large enough, but our search returned these 15 original research studies that were comparing red cell transfusion to no transfusion, specifically looking at mortality outcomes. The total number of patients included in these 15 studies was over 14 million, and the range of participants was between 12,000 and 10 million. You can see the populations that it was drawn from: cardiac surgery, lung transplant, hip fracture, upper GI bleeding, intracerebral hemorrhage, neonatal surgery. Importantly, we sort of identified 3 different types of studies. The first were, and these were the majority of them, were your transfusion versus no transfusion type study. The second type of study that we identified here were the ones that were looking at 1 unit of red cells compared to no red cells. And the third type of study were what we call dose escalation comparisons. Now, if we cut to the chase and get straight to the forest plot in this review that we conducted specifically for this presentation, starting with our general studies, this was the largest group. These were studies that were comparing patients receiving red cell transfusion to patients that were not transfused. And as you can see from our forest plot here, we get a very similar picture to what Hopewell and colleagues described in their 2013 review. So if you remember their conclusion, they found a consistent adverse effect of transfusion with mortality. Well, 10 years later, what are we saying here? Well, if you look at our forest plot, you can see that each of the studies identified, these large studies with 10,000 patients or more, each of these studies identified that red cell transfusion was associated with increased odds of mortality, every one of them. So our results here between the studies that were pooled are consistent. Hopewell and colleagues' 2013 study, their results between the studies were consistent. So I guess 10 years later, we could say that we have consistency, which is remarkable. And we can touch on why consistency is so important later on. Now, they did make a comment, though, Hopewell and colleagues, in their 2013 paper, and it was a however type comment that they were saying makes the interpretation challenging. And that was, they were saying that there are confounding factors in these observational studies that mean patients who receive blood are generally sicker than those who don't. It's very hard to, and this is a statement that's commonly made, I'm sure you've read this many times in the literature, it's very hard to put a definition on what sicker actually means and how that changes between patient groups. But that's why these next group of studies are so important. So this is the second group of studies we found in our review. And those are studies comparing a single unit of red cells to patients receiving no transfusion at all. These studies are obviously very informative because it is reasonable to conclude that patients who receive 1 unit of red cells during their entire hospitalization, they're more likely to be receiving a discretionary, potentially avoidable transfusion. And we could also say that the patient is less likely to be sicker. So in this study here conducted, you can see on the screen, conducted between 2010 and 2019, there was an analysis of over 2 million adult patients undergoing isolated CABG or isolated valve replacement. Over 2 million, of which 400,000 were included in the propensity score matched analysis. And these propensity score matched analysis, these techniques are designed to replicate the way controlled trials work. And in these 400,000 patients, in that comparison, they found that there was a 1.45 times increased risk of operative mortality in patients receiving a single unit of red cells when compared to patients who were not transfused. So that's just one example. There were other papers like that. Now, we'll also look at dose-response relationship. This was the third type of study in our review that we identified. And these are studies that are looking at that dose-response relationship between the number of units of red cells given and mortality. So the first large study we're looking at here on the screen, this comes from the National Health Insurance Database of South Korea. And it looked at patients undergoing their first open heart surgery procedure between 2002 and 2019. And we've got over 75,000 patients in this. Now, when comparing patients receiving 0 units to those receiving 1, 2, or 3 or more units of red cells respectively, they found increasing adjusted hazard ratios for mortality. Another similar study was conducted on US patients, and this one extracted over 750,000 patients from the Society of Thoracic Surgeons Adult Cardiac Surgery database. This was in patients undergoing isolated CABG procedures. And they used slightly different groupings than the previous study for red cells, but very similar results. We could say that when comparing patients receiving no red cells to patients receiving 1, 2, 3, or 4 or more, there was an increase in the adjusted hazard ratios for death again. So we see that same pattern. And so what we see are, again, consistent results, and we're seeing a dose escalation relationship. So that's a very quick summary of what we can learn from very large studies looking at red cell transfusion and outcomes. These are studies with over 10,000 or more patients published in the last 5 years. How do we piece this all together though? So our third question, what can we learn from randomized control trials and observational data regarding causation? So everything we've looked at until now is these large studies. Typically, these big data or large data studies are with observational data. And randomized control trials are considered the gold standard in research. And I'm sure you are also aware that many consider randomized control trials are the only way to establish causation. That's a view that many have. So it is appropriate to have a look at, well, what do randomized control trials show? And are they consistent with the results of these large data studies? Well, we conducted, some time back, we conducted an overview of systematic reviews. So just to be clear, this isn't a systematic review or meta-analysis. This is a systematic review of systematic reviews that were pooling randomized control trials. We searched, as you can imagine, we searched multiple databases for these systematic reviews and meta-analyses, specifically of randomized control trials that were comparing mortality in patients assigned to red cell transfusion strategies based on their hemoglobin thresholds. And this was over a 10-year period. Now, among other things, what we found were 68 unique randomized control trials. There's a lot of randomized control trials comparing two transfusion strategies. And these were pooled by 19 systematic reviews. And just to get straight to the point, I'll show our forest plot here of the results. The conclusion from combining all of this data from all of these randomized control trials and systematic reviews and meta-analyses that were pulling all these randomized control trials is that these meta-analyses indicate that in most patient populations, there really is no difference in mortality between patients assigned to a restrictive or to a liberal transfusion strategy. If you want to get more specific, more accurate, 75% of the meta-analyses showed no difference. 25%, so a quarter, showed that there was lower mortality in patients assigned a restrictive strategy. Now, here's a key point from this presentation. This may appear to contradict the results from these large observational data studies which have been showing till now, which have consistently showed increased mortality with patients receiving red cell transfusions. And as a result, some have incorrectly interpreted this to mean that, well, transfusion is not associated with harm, because these large studies are just overestimating the relationship. Now, this to highlight this point, this figure we have on the screen, this was published in the Canadian Journal of Anesthesia. And here, this article tries to describe what they feel is a discrepancy between the results of observational studies, which are in blue, and randomized control trials in red. I believe in this specific example, they were looking at cardiac surgery studies. Now, what this shows, if you look at the difference between the blue bars and the red bars on the forest plot there, what it's showing is that observational studies consistently find higher mortality and morbidity in patients transfused. They're the blue bars. Randomized control trials don't. They're the red bars. What's the reason for this? Well, the authors suggest that this discrepancy may be due to the fact that observational studies are associated with possible confounding, whereas randomized control trials have minimal confounding. Now, I'm using this as an example, but there are plenty of examples in the literature and probably down the hallways of your hospital too, where the reason given for the difference between observational studies and randomized control trials is that observational studies are prone to confounding and they overestimate. Now, that blanket assumption is incorrect. Let's explain why. Here's a Cochrane, this is from the Cochrane Library. And if anyone knows what the Cochrane Library represents, we can understand why this is so significant. And this was comparing randomized control trials to observational studies. So if we go back to the example we looked at just earlier with, well, actually, before we do that, let's have a look at what this study actually did. Now, this review, pulled 2,800 plus randomized control trials with nearly 4 million participants and compared those to nearly 4,000 observational studies with nearly 20 million participants. And look at what they concluded. They concluded that there was no difference or a very small difference between the results from randomized control trials and observational studies. They also say these findings are largely consistent with findings from recently published research. And in fact, this isn't the first time a large study like this has been done. This has been consistently shown for some time. There's even a series of articles in the New England Journal of Medicine from 2000, that's 24 years ago, saying the same thing. There's no difference or very small difference between the results of observational studies and RCTs when the methods are the same. What do they go on to say? And this is very important. Factors other than study design need to be considered when exploring the reasons for a lack of agreement between the results of RCTs and observational studies. Now, this is very insightful, such as the differences in the population, intervention, comparator, and outcome. So let's go back to our Canadian example and let's see if they've perhaps missed something here. And I would suggest the authors have missed a key point that we've just highlighted from that huge Cochrane review. And many more have warned against it. And that is, we shouldn't be basing the perceived discrepancy between those blue bars and red bars on the fact that one of those comes from observational studies and one of those comes from randomized control trials, when we've completely forgot to consider that there's a difference in the intervention and comparator. They're investigating two very different things. It's like comparing, you could say, I don't know, apples and oranges. So let's just pretend that our restrictive versus liberal randomized control trials are apples on the left, and these large observational studies we've considered till now are the oranges on the right. Well, one's asking if it's safe to use lower hemoglobin thresholds for transfusions. The other is asking what are the outcomes associated with transfusion. The intervention and the comparator between these studies are completely different. In fact, you notice the oranges are comparing 100% transfusion rate to a 0% transfusion rate. So that intervention and comparator is completely different to a randomized control trial looking at triggering a transfusion at a higher hemoglobin versus a lower hemoglobin. So we wouldn't expect these results to be similar. Just to highlight the big implications of what we're talking about here. Some questions simply cannot be answered by a randomized control trial. And when those questions cannot be answered by a randomized control trial, the highest level of evidence we have available are well-conducted observational studies. And the results of that Cochrane review highlight that when we have a well-conducted observational study, well, we would expect those results to be similar to a randomized control trial. So the implications are important. So let's put this in historical context. I'm not sure if you're aware of Sir Austin Bradford Hill. So he has been credited with the first published randomized control trial in medicine. It appeared in 1948. It was looking at streptomycin for the treatment of tuberculosis. Many might be aware of this, that he was a very well-regarded statistician who designed the clinical trial and really credited with conceiving the modern randomized control trial that is a mainstay of research today. Now, let's be clear, no one denies that randomized control trials, when well conducted, have strengths. They also have their limitations. And this is where observational studies are particularly valuable. To repeat the point, when a research question cannot be answered by a traditional randomized control trial, some classic examples are smoking versus non-smoking, which applies very well to Bradford Hill. So he conducted the first randomized control trial with streptomycin, as we said, but later on in the 50s, he was involved in those large observational studies which determined the relationship between smoking and lung cancer. They couldn't conduct a randomized control trial. They conducted a series of observational studies, and they were able to establish causation. So questions like, what effect does transfusion have on outcomes? The best evidence we're going to find is going to come from well-conducted observational studies. And here's an excellent study, an excellent publication. It's from 2011, but it just amazes me how ahead of their time they were in publishing. This is published by Isbister and colleagues, and many of these authors here you'll recognize. These authors that have published a lot in this space, and they've applied the Bradford Hill criteria for establishing causation from observational data to the adverse effects of blood transfusion outcomes. So this really highlights the valuable role and contribution that observational studies, these large data studies, and we're going to get into more of these big data studies. This highlights the implications that these studies have for helping us to draw robust conclusions from our data. So this is an excellent article, and I'm sure you'll enjoy reading it. So just to wrap up what we've looked at in this presentation. First of all, the first point, that a key point to take away, is that big data is more than large data. Sure, big data does involve large volumes of data, but it involves a lot more. It involves things like data that comes from sensors at very high frequencies, and it involves unstructured data like waveforms and that kind of things that we're not collecting, that we can't store in traditional SQL databases. There isn't a lot published in the transfusion space using big data, but we can really sense the floodgates are about to open. So get ready to see more publications in that space. The data we have from very large data studies have really highlighted that transfusion is associated with adverse events. And this is our second conclusion here, that statistical models and our machine learning models on large data are consistent about the adverse effects associated with transfusion. They've produced consistent results for many years now. And our third point is that, as we've looked at using the example of the Sir Bradford Hill and the Bradford Hill criteria, that data from large observational studies should not be underestimated. And they are going to be very important in assessing the relationship between transfusion and outcomes. And thank you very much for your attention. I appreciate it.
Thank you, Dr. Trentino, for that extraordinarily clear and interesting and clinically important talk. And welcome to the Bloodless Medicine and Surgery Society. We're going to now move on to our next talk, which is going to be the Arieh Chandra lecture by Dr. Krista Simito. And his lecture is entitled Making the Case for Bloodless Surgery Programs in Developing Countries. I should say a few words about the Arieh Chandra lecture. It's been a feature of these meetings since 2019. I'm sure Arieh, who I know very well, is very happy that this is not a memorial lecture. And the first lecture was delivered by the man himself, Dr. Arieh Chandra, in 2019, who's been an active member of the society and one of the foremost contemporary bloodless medicine practitioners at Englewood Hospital, where he and others founded literally one of the world's great programs. So the aim of this lecture is to encourage the improvement of clinical outcomes and protection of patients' rights through the promotion of the science and practice of bloodless medicine and surgery. And the lecturer is always a person with a track record of outstanding academic contributions. I'm going to give a very brief introduction of Dr. Simito, and I hope I pronounced his name correctly. He's a consultant surgeon at Luantria Mine Hospital in Zambia, and he has a distinguished career as a surgeon, having been a member now of the Royal College of Surgeons of Ireland and Edinburgh. So he's spanned the British Isles there, and he's had many positions involved in taking care of a variety of different surgical patients, even including obstetrics and gynecology, and his commitment to education and to teaching is well documented. He's currently a consultant surgeon in Zambia, where he manages a wider variety of surgical conditions for the mine's employees and registered members, and he's been providing bloodless medicine and surgery service since 1989, before some of our members were born. So I will welcome him and let him share his screen.
Thank you very much for those kind words. I will share my screen. So, making a case for bloodless surgery in developing countries. As an introduction, being a surgeon, just a brief on surgery and a bit of anatomy. So surgery involves removing, repairing, or diagnosing a part of the human body. Hence, surgical procedures often result in blood loss, necessitating sometimes blood transfusions, especially in major surgeries. A bit about anatomy to understand why there is bleeding during surgery. The blood circulation system delivers the nutrients and oxygen to all cells in the body. It consists of the heart and the blood vessels running through the entire body. The arteries carry blood away from the heart, and the veins carry it back to the heart. The smallest arteries, the vessels called arterioles, further branch into tiny capillaries where nutrients and wastes are exchanged, then combine with other vessels to exit the capillaries to form small venules. They are small blood vessels which carry blood to a vein, and larger blood vessels that return the blood to the heart. So therefore, in surgical procedures, there is always some bleeding. So the art of surgery involves making a cut through the skin into the tissues to reach the diseased part. This is always accompanied with some bleeding, as some capillaries and veins are also cut. Blood transfusion, a lifesaver with risks. The history of blood transfusion dates back to the 1600s and the human-to-human transfusions in the 1800s. There has been a lot of developments and advancements in blood transfusions to make blood transfusion safe. And these are well documented. But we find that even with advanced technologies, we still see some complications attributed to blood transfusions. And these are like transfusion-related acute lung injury, like the allergic reactions, and transfusion-associated circulatory overload. And sometimes we see febrile non-hemolytic reactions and also the complications of infections. Every transfusion interferes with the recipient's immune system. So that's the well-documented fact. So every transfusion interferes with the recipient's immune system. And then there is this increased risk of infection. So a number of experts have been working around the clock, including the past speaker, who have been working around to see how do we improve this. And they came up with the term patient blood management, which was presented to the World Health Organization with evidence. And it has been supported highly and recommended by the World Health Organization in their whole policy brief of 2021. What is patient blood management? This is a patient-centered, systematic, evidence-based approach to improve patient outcomes by managing and preserving the patient's own blood while promoting patient safety and empowerment. The definition emphasizes the critical role of informed choice. Patient blood management involves the timely, multidisciplinary application of evidence-based medical and surgical concepts. And these are aimed at 1, screening for, diagnosing, and appropriately treating anemia. 2, minimizing surgical, procedural, and iatrogenic blood losses and managing coagulopathic bleeding throughout the care. And 3rd, supporting the patient while appropriate treatment is initiated. This World Health Organization policy brief really calls for urgent need to implement patient blood management. It raises the importance of managing anemia and, in many instances, blood loss and coagulopathy, because taken together, these conditions represent one of the world's biggest, largely preventable, yet greatly underestimated public health and health economic burdens. The policy brief itself highlights the wins with patient blood management, and these are: 1, significantly improve global population health and the clinical outcomes of hundreds of millions of surgical, medical, and obstetric patients. 2, to reduce health care costs. 3, to improve patient safety. 4, to advance patient education and empowerment. 5, significantly reduce the demand for allogenic blood components and thus the national dependency on transfusions. The 6th one, to mitigate some of the resource constraints in healthcare, particularly for low-income countries and the low-middle-income countries. While trying to preserve the blood, patients' own blood, there is this topic coming up of blood health. Knowing it and understanding blood as an organ is very important. So blood health is the optimal function of individual elements of blood and their associated interactions with all the organs and the organ systems. So PBM is a patient-centered, evidence-based approach to preserve the patient's own blood, to preserve the patient's own blood and improve the outcomes. In patient blood management, we talk about three main pillars. And there's one, two. The first pillar is screening for anemia and appropriate treatment. The second pillar is minimizing blood loss during procedures and managing coagulopathy. The third one is supporting the patient with timely elements. Anemia is very common in the developing countries. So just a bit on anemia. We see that anemia constitutes a public health problem in developing countries. The underlying causes of anemia are many, varied, largely preventable, and these include nutritional deficiencies, infectious, and hemoglobinopathies. Globally, it is estimated that in 2019, 40% of all children aged between 6 and 59 months, and 37% of pregnant women, and 30% of women 15 to 49 years of age were affected by anemia. The World Health Organization African region and the World Health Organization Southeast Asian region are the regions most affected. It is estimated that nearly 1/4 of the world's population of 1.8 billion people suffered some form of anemia. So we can see that anemia is quite key, and something must be done to improve it. Bloodless surgery. Just an overview. This is the provision of quality surgical care without allogenic blood transfusions. And it focuses on patient rights and clinical outcomes and safety. And it follows the patient blood management principles and the pillars. And we'll discuss more on the pillars. The challenges that we face in the developing countries are many. We see that in the developing countries, the hospitals are located both in the rural communities and in the cities. The hospitals in the rural communities tend to have less equipment, tend to have more general doctors than specialists, and more specialists we found in the bigger hospitals in the cities. But you'll find that even in the bigger hospitals in the cities, not all of them have necessary equipment. Hence, blood transfusions are common in major hospitals. Some of the major operations where you find that there is a lot of bleeding are cesarean sections, hysterectomies, and laparotomies for intestinal obstruction, operations on the thyroid gland, and also in trauma surgery. So there's a high blood loss in surgeries. Anemia is common, leading to even more need for transfusions, and also there's inadequate medical equipment. So there is need for bloodless surgery in developing countries. This will help to reduce the risks and the complications and infections which occur. Okay. And also, it aligns quite well with the World Health Organization patient safety and outcome improvement goals. The Global Patient Safety Action Plan for 2021 and 2030 reads, the goal is to achieve the maximum possible reduction in avoidable harm due to unsafe healthcare globally, envisioning a world in which no one is harmed in healthcare and every patient receives safe and respectful care every time, everywhere. There are a lot of programs taking place at present worldwide, which are there to provide bloodless programs. And there are more than 250 programs worldwide, and they are named differently. Some are just named the bloodless surgical programs. Some are patient blood management programs. Others are transfusion-free medicine programs. So there are these programs in a number of hospitals already which are working, but most of these are actually in developed countries. We'll go back to the pillars of patient blood management. They are the three: one, to optimize the hematocrit; second, to minimize blood loss; and third, to support patient tolerance of anemia. In bloodless surgery, sometimes we actually add the fourth pillar. So the first one, to optimize the hematocrit; second, minimize blood loss; third, optimize tissue oxygenation; and fourth, support physiological tolerance of anemia. A bit more on these. The first one, optimizing the hematocrit. We go back to the history. As I said, anemia is very common, so it's very important to getting a very complete history. When anemia is found, it must be treated. Initially, one can start with just oral iron therapy, where if someone still has time before the operation to be done, or if you want to bring up the hemoglobin very fast, you can use parenteral iron therapy with adjuncts of vitamin C, folic acid, and vitamin B12. It is very important to continue providing nutritional support. And then the erythropoietin is key also in helping to increase the hemoglobin faster. The second pillar in minimizing blood loss, you still go back to history, make a good diagnosis. And when the patient is in hospital, we avoid frequent phlebotomies so that we don't reduce the blood. Okay. What is key is also tranexamic acid in most of the surgeries that were used. And with a good team of the anesthetists and others, one can be able to do a good operation in most of things. Meticulous hemostasis and using a tourniquet, that is key. The technique that we want to use in theater is very important. Some countries are now coming across to have a cell salvage, which is key for reinfusion in terms where there's more blood loss taking place. After the surgery, it is important to still maintain the patients. So volume replacement is key so that there is enough blood circulating around. And where the hemoglobin becomes a bit low, oxygen therapy can be given as well. It is important to avoid the patient being restless, because being restless or being in severe pain can actually increase the need for oxygen and also make the patient's condition quite bad. So it's important to always give oxygen. Important to manage the patient's pain management is very key. Okay? Where someone's blood pressure is low, they might need to give inotropic drugs as well. Continuing with managing the patient post-surgery, we need to institute measures to make that the blood pressure is stable. So the support of always giving IV fluids and starting the nutrition early, that is good. Okay. The point of care testing, I think in some developing countries, we're able to have this just for checking HB, not a full blood count, just for checking HB, just a small drop of blood that one is needed. and one can actually check the hemoglobin. So this is an area also post-op, the patient needs to be managed adequately to make sure that there is no complication. So how are we doing in the developing countries? Well, in Nigeria, I think the University of Calabar has a well-established bloodless program. So I thought we could use them as an example of how their program is doing very well, bringing out improved clinical outcomes and reducing the need for blood transfusion. So there are two cases that I'll present. Like this from the Calabar, this patient who's 42 years old, who presented with an 11-year history of a painless swelling in the anterior neck swelling and was breathless. And she traveled 200 kilometers to reach this facility. You can see the need for having bloodless programs will quite spread so that the patient don't need to travel so long distances. So she had this neck mass, and which also affected the breathing of the patient because there was a stridor and the tracheal deviation. And the diagnosis on ultrasound showed that actually she had a multicystic multiple nodular. So she was prepared for operation. So the surgical team made a plan. Okay, the plan was to initially bring up the HB, which was low, and then plan for a bloodless subtotal thyroidectomy. And they used tranexamic acid to reduce the bleeding. And there was meticulous intraoperative blood conservation techniques. So here you find it is important for the operating surgeons to know the anatomy of the organ where they are operating. They should know where the blood vessels are, so that when they are doing an operation, there is less bleeding if they know what they are doing. Okay. This is the continuation of the operation. Meticulous surgery, knowing where the bleeding is, and then you do a good operation, bloodless operation. Earlier on, I said you find that in the countryside, we have general doctors who are not specialists, and they would tend to do a lot of operations, like cesarean sections. When they're operating, they might not be aware of where blood vessels are, and as a result, patients bleed a lot. And these are the areas where you find that they need more blood transfusion. So intraoperative on this patient, they gave tranexamic acid, which is very, very important. And this patient recovered quite well. And HB from 11 came to just 10.3, and the follow-up was quite well. The second one was an emergency. It's a female who after delivery, had vaginal bleeding for 1 hour. Okay. So that was bleeding for 1 hour, leading to active labor. Both fetuses were delivered, but one was stillborn. The cord prolapsed and others died. So there was severe obstetric hemorrhage with blood loss exceeding 2,000. That's 2 liters. That's a lot. The patient refused the blood transfusion. The patient was resuscitated with IV fluids. The hemorrhage management, they gave oxytocin, they gave tranexamic acid and uterine massage. But you find that even despite what was given, the bleeding continued. And the patient, his HB became very low to 3.3. And then the decision was made to actually take the patient to theater. And they found an atonic uterus with a lot of leiomyoma, so fibroid uterus. So a hysterectomy was performed, so removing the whole uterus, and she lost a lot of blood. We were talking about almost 4 liters. Total blood volume is 5 liters. That was quite bad. The patient was extubated, transferred to ICU. Look at the HB, it came to 1.8, but this patient was well resuscitated with IV fluids, antibiotics, and oxygen therapy. Okay. There were even some seizures, but the patient still recovered from that. He was given iron dextran and erythropoietin. The outcome was that the patient was eventually discharged from hospital with HB of 6.9 at the full recovery. So this was a successful bloodless management of severe obstetric hemorrhage in a resource-limited setting. With a good team, it is possible to achieve. Okay. So bloodless surgery is essential in improving patient safety in developing countries. So collaboration is needed to scale up such programs. Okay. So with this collaboration, others can be taught how to make these multi-committee programs. And then the focus really is on patient rights and clinical outcomes. So it is possible to have bloodless programs in developing countries, and it can help to achieve the goals that the World Health Organization and all the member countries have actually implemented and want to achieve. Thank you very much.
Wonderful. Thank you so much, Dr. Samutu, for that excellent lecture and the R.A. Shander honorary lecture. Please remember, everyone, as you are listening today, to enter your questions into the Q&A section of your Zoom screen. As you collect those questions, when we get to the Q&A session at the end of all of our speakers, we'll be glad to bring those questions forward to our speakers and to our panelists to have them answered. So please don't hold back, enter those questions at any time. I'm thrilled to be able to present the next lecture to you. It is going to be a co-presentation between two speakers. So I will be giving a bit of an abbreviated introduction to both of these speakers in the interests of time. So the next lecture is presented by Dr. David Jadwin, and as well it's going to be co-presented by Elliot Fieldhouse Allen. So Dr. Jadwin is the president of Columbia Healthcare Analytics, which he founded to provide educational feedbacks to physicians about their case management. David is a fellow of the College of American Pathologists and has served as department chair for a number of hospitals. And he has a career that spans back to 1968, where he started out as a medical lab technologist, then obtained his graduated in biochemistry before receiving his Doctor of Osteopathic Medicine. Then he completed his anatomic and clinical pathology residency in San Antonio, Texas. He's also had a career in emergency medicine as well. So David has published a very pinnacle article, Determination of Unnecessary Blood Transfusion, which was a comprehensive review of 15 hospitals. And this was done in the Joint Commission Journal on Quality and Patient Safety. And now a larger study with 53 hospitals and hundreds of thousands of patients is being conducted. And I'm hopeful that we'll hear a little bit about that today too. So Elliot Fieldhouse Allen is a managing director of DataWise Artificial Intelligence Limited and a technology director in Eye in the Skies Limited. So David is a leader and an innovator in AI-driven solutions, which cross healthcare, education, and drone surveying industries. So he has a background in computer science and artificial intelligence, and his DataWise AI Limited is an AI consulting agency. And so he has partnered with Columbia Healthcare Analytics to develop groundbreaking AI applications in medical diagnostics. So as also as technology director of Eye in the Skies, he leads development of AI-powered drone imagery and analysis with environmental monitoring solutions. So very exciting subjects here. So we're thrilled to be able to welcome Dr. David Jadwin and Elliot Fieldhouse Allen. Thank you.
Thank you, Becky, and the Society for inviting me to speak today. I don't know if Elliot will be able to talk during this session. He may present later in the week. It's still under discussion, but let me share my screen with you. Well, hopefully you can see everything here. So my talk today is about, and I spoke in May a little bit about this as well, but it's about patient blood management analytics. And as far as any disclosures, I am the president of Columbia Healthcare Analytics. I have worked since 2006 without any compensation, so I have no financial complex, and Elliot will speak about his. So our objectives today, going through these fairly quickly, is that why computerized physician order entry needs to be improved. We'll discuss some data measures of avoidable blood use. We'll talk about a study that we're doing right now and hope to be beginning an intervention study to show how we can rapidly change physician behavior, how to better report blood use and particularly patient blood management, and some applications of artificial intelligence in healthcare and patient blood management, which Elliot will talk about probably later this week. The purpose of the data is to show physicians that most patients can be managed without blood use. That's really the key focus here. So as was mentioned, we did publish a study last year, a 15 hospital study, where we reported that 45% of patients, plus or minus 15%, could have been managed without transfusion of any type. And these largely stem from the use of laboratory criteria such as hemoglobin less than 7 or an INR greater than 1.8, which are not indicators of good blood management. That's just a level below which you can transfuse, and we probably won't look at what you're doing. Unfortunately, hospitals have gotten away from doing any chart review, and they've gone to dashboard metrics such as the percent of patients who have a hemoglobin above or below 7. And there's nothing magical about 7. So what are some of the basic principles of good patient blood management? Well, the first is to control or stop the bleeding, timely clinical and laboratory evaluation. You can't believe how many times people don't get an anemia workup until after they've received a half a dozen units of blood. Optimize the patient, looking at anemia and coagulopathy, evaluate the patient and provide good documentation. When I look at thousands of charts, the indication in the progress note is the patient's anemic. I mean, that's all they document. Individualized patient management. Don't just respond because the hemoglobin is less than 7, and be conservative. In other words, don't rush to transfuse. Oftentimes you can wait 12 hours, 24, 36 hours in many situations. And finally, the current CPOE, such as hemoglobin less than 7, are not measures of good blood management. They don't tell you whether they could have corrected the anemia, 3 weeks ahead of time. So if these CPO indicators aren't that great, what are some of the ones? Well, we advocate really 3 attestations that the physician has to do. So they're not checking the hemoglobin less than 7. They're saying, number 1, life-threatening bleeding is present, and they're attesting that non-transfusion modalities have been implemented, hemostatic, pharmaceutical, cell salvage, etc. These are far less than 5% of all cases. The second category is patients with severe anemia impacting organ perfusion, and the physician will attest that timely anemia workup has been implemented, not performed, and timely IV iron and erythropoietin stimulating agents have been initiated. And the third one is that there's a significant risk of significant bleeding from coagulopathy, and they're going to attest that timely pharmaceutical treatment has been initiated. So instead of checking the hemoglobins 6.9 or less than 7, they make these attestations. And there's a final caveat: if it is a surgical patient, then they're going to attest that pre-admit preoperative anemia has been addressed, timely non-transfusion modalities are employed, and appropriate testing has been completed. So as was mentioned in this 50-plus hospital study, 16 health systems, 350,000 patients, a very simple study. We're looking to see how much has blood use changed between 2016 and 2023. We have many hospitals, we have data going back to 2009, but not all the hospitals have that. So we segregated 2016 and 2023, and we also broke those down into pre-COVID, COVID, and post-COVID sets. So this is a very simple study looking at just the discharge hemoglobin in patients that received a red blood cell, looking from 2016 to 2023, and seeing how much has the median discharge hemoglobin confirmed. Now we're just in the middle of doing the biostatistics on this. It's probably going to be ready for publication just in a couple more months. But I think you can see the median hemoglobin is around 8.5. It really hasn't changed much, other than some variation during COVID. Same thing for patients who got a total of 1 or 2 units of RBCs, around 8.5. That means half the patients have a discharge hemoglobin above 8.5, as you'll see sometimes up to 16, 17 grams. So that was a monthly run chart. This is the annual chart, so you can see the annual variations here, and you can see that the slope is very slight. I think it's improving like 0.1 gram per year as far as reduction. A lot of this has been actually more since COVID. So that's the median discharge hemoglobin. So let's look at the patients who had a discharge hemoglobin above 8 grams, and 8 grams is rather high. Look at the percent of patients who would be over transfused, hemoglobin is above 8, and you can see it's around 80% for all RBCs. 1 unit and 2 unit RBCs. Again, the drop here is probably a little bit more towards COVID rather than as a response. So we can then calculate what we call the median transfusion-free index, which is we're going to take the discharge hemoglobin, we subtract the hemoglobin they receive from RBCs, 1 gram per deciliter, from the discharge hemoglobin to get a crude estimate of where the patient might have been without RBC transfusion. And we can see here that about 40% plus of patients likely could have been managed without RBCs, just based on the discharge hemoglobin alone, without looking at missed opportunities to treat anemia or diagnose anemia, control bleeding, etc. For 1 unit, it's about 80%, and for 2 units, it's about 40. Well, it started at 60 and went down to 40%. Now, in our paper, reported that if patients got 1 unit of blood, when you did a complex chart review, page by page, vitals, labs, medications, etc., 90% of the time they didn't need that single unit. And if they got 2 units of blood, 60% of the time they didn't need those 2 units of blood. And here we can see, just based on this, it's about 40%. This just shows how we can compare hospitals. So this is a large academic hospital, and we're looking at the median, a monthly run chart, the median transfusion-free hemoglobin for all RBCs. You can see they're substantially above the median curve for the group. So what is acceptable performance? Well, this is a large 800-bed hospital. This is over-transfusion for all RBCs and 2 unit. We don't use 1 unit because if they didn't need the 1 unit, that's not particularly over-transfusion. So you can see that there really hasn't been much of an improvement over a number of years in this hospital. Now we can look at the transfusion-free run chart, and this is 1 unit transfusions, 2 unit, and all RBC transfusions. You can see really there hasn't been much of an improvement. So what is an exceptional, what's an acceptable level? Well, here, this is very interesting because this is the only hospital that we've seen this impact, where they actually had a reduction in their blood use back in the 2015, and has steadily increased ever since then. And this is so long ago, no one even remembers what they actually did here, so it's unfortunate. But it does show that it is possible to get down to 20-25%. It's probably unrealistic to think that this will ever go to 0 or even 10%, but it does show that you could get this down to around 20%. And so what we want to do is we've applied for some funding to do an intervention study where we actually pay the physicians to participate, because physicians are so busy they don't want to even look at anything. So they'd actually be paid to look at their cases and see. When we show them the data, we talk to them, we give them their own case feedback to see if we can bring this curve sharply down here. And we're actually applying for a fairly large grant in Africa, taking this technology, not just for blood use, but for healthcare in general, using artificial intelligence. And we're coupling that with the LA County Health System and hopefully others as well, to take cost savings from LA County and to send 10% of that back to other low and moderate income countries. So this is another study we just did. This is just 19 months for the most recent study. This is one of the hospitals we have data going back for to 2009, but it's a 500 plus bed hospital, 19-month study. And this is just looking at the transfusion-free discharge hemoglobin for 1 or 2 unit transfusion. You see they did around 7,500 each, about 15,000 units. And these are the bins for the discharge hemoglobin, say from 7.1 to 7.5, 7.6 to 8, etc. And you can see the extent of over-transfusion here, the blue being perhaps the ones that may need transfusion, although I think if many of these patients are Jehovah's Witnesses, they'd probably do well. And of course, this translates into a lot of money, around $5.5 million over 19 months. Now we can take, if we have physician-specific data, we can actually create a scorecard. So I know that some people look at the pre-transfusion hemoglobin for people, which I think it has some limited value for a lot of reasons, but I think it makes more sense to look at the discharge hemoglobin. So this is a physician, the top one, they had 169 physicians, the top transfusing physician, 190 to patients over 19 months, or about 10 patients a month. He had 88 1-unit encounters and 46 2-unit encounters, or 82% of patients got 1 or 2 units. What does that tell you? That a high percentage of those patients probably could have been managed without transfusion. Then you can look at their median hemoglobin for 1 and 2 units. So in this case, it's 8.1. So half these 1-unit transfusions had a hemoglobin, transfusion-free hemoglobin above 8.1, and for RBCs equal to is 8.7. And then you can look at the percent of patients who likely could have been managed just based on the discharge hemoglobin. In this case, it was 68%. Down here, it's 85%, 85%, 92%, et cetera. So we can look very quickly to see, who are the heavy hitters. And by the way, out of the 169, there are probably about 90 physicians that transfuse less than 5 units of blood over 19 months. So some question could be if those physicians should actually be prescribing blood, because they do it so infrequently. So in this study, anyone can participate. We're hoping that maybe some people will contribute. It doesn't cost anything. It takes very little time. It doesn't take time from your blood bank or your laboratory work with discharge procedure reports. It's anonymized, so we don't need any patient identifiers. We look at data going back as far as we could, even 20 years if possible. We're just looking at the discharge hemoglobin, the admission hemoglobin, if available, the various components, the admission, discharge date and time, the age, gender, discharge status or disposition, the primary diagnosis, hospital service, and then the ordering physician identification. So finally, how should patient blood management and blood use be reported? And I can't tell you how many various blood use committees I have sat in on. And the most recent one, they spent about 40 minutes just talking about the components transfused, the components wasted, outdates, and whole blood hemostatic testing. Now, there's nothing wrong with hemostatic testing, but the amount of blood that this is going to save is relatively small if most of these patients are getting 1 and 2 units, and that's constituting at least 50 or 60% of the units. So it really makes sense to look at these small things. But these should be, as a pathologist, I've sat on these for decades, and this should at most be information, and probably not more than 3 minutes. In fact, you can probably just send this information. If it has an assessment and a plan, you can probably just distribute these to people. And then if there's any comments, they can add that even by email. The second phase of this is really looking at your adverse transfusion events, the serious and the minor ones. Again, these are informational only. If you have a serious one, they probably should have a casework and not necessarily a discussion at the committee. If they need a chart review, that probably should be done offline, and then a plan. But this is where the real nuts and bolts are, is looking at the transfusion and patient blood management. In all the committees I have sat in on, they hardly ever touch these things, such as the massive transfusion events, the number, and their outcomes. They oftentimes leave out the outcomes. Prospective transfusion interventions, which I think are pretty cavalier. Most people get their, if they say they have a bleeding, GI bleeding or this or that, they usually get approved. When we look at these after the fact, they almost always are unnecessary. Appropriate anemia workups, pharmaceutical reports, which is often not done. Again, the RBC1, 2, and et cetera. And then this you can read online, but these are some other comments about how to run a blood usage committee. And then finally, it is possible to review charts in a matter of minutes now, and you can actually count the number of times that a patient might have been a candidate for iron studies or anemia workup, in this case, 28%. Patient a candidate for IV iron, 18%. Patient candidate for IV iron and or with their potent, 17%. So 35% of patients right there. Additional IV iron, 7%, and earlier IV iron, 6%. When you add all that up, you can see this. So that's pretty much this point. I think Elliot will probably speak later this week. And so I hope we've covered these objectives adequately, and that the purpose of this data is really not to tell physicians what to do. Everyone tries to tell physicians what to do, and I've heard a lot of academic pathologists, et cetera, say they really, and even surgeons say, I try to go around tell doctors they just don't want to listen. So if you can take their data and show them instances why they are over transfusing, you have a much more powerful tool to change physician behavior than just trying to do educational sessions. Thank you very much. Any questions?
Thank you, Dr. Jadwin. We're going to leave the questions till after the keynote addresses are done. And I want to thank you and your colleagues for putting together really illuminating and clinically important studies that will shape policy going forward, hopefully. This has been a very illuminating experience. So I think even though we're a bit early, if Dr. Frank is available, and I see him here, I would like to introduce our final keynote speaker, Dr. Stephen Frank. Dr. Frank is well known to many of you. He's a professor of anesthesiology. Dr. Frank is well known to many of you. He's a professor of anesthesiology. Dr. Frank is well known to many of you. He's a professor of anesthesiology. Dr. Frank is well known to many of you. We're having some technical difficulties. Let me try that again. Dr. Stephen Frank is a professor of anesthesiology and medical director of the Center for Bloodless Medicine and Surgery, and also director of the Patient Blood Management Program at Johns Hopkins. And he, in terms of his clinical work, he specializes in anesthesia for vascular, thoracic, and transplant surgery. And he is well known to you for his many interesting and clinically important publications on how patient blood management and bloodless medicine and surgery can illuminate and further our ability to take care of patients with better outcomes. And so he's working on, as Dr. Trentino talked about, large data and even bigger data. And he's on editorial boards of important journals, and he's served on the board of directors for the AABB and the Society for the Advancement of Blood Management. And he, in his capacity as an anesthesiologist, he has been chair of the Patient Blood Management Committee for the American Society of Anesthesiologists. He's won awards for teaching and for clinical excellence. And he, in fact, won an award from this society in 2021 for his contributions. So, Dr. Frank, share your screen and let us share your wisdom with us.
Thank you, Neil. Can you guys hear me and see me okay?
Both are fine.
Okay. Thank you, Neil, for that kind introduction.
I'm afraid
I'm
you're
not sure how good my
we're breaking up
internet
a bit.
connection is where I'm at right now. Do you guys see this? And
Yeah.
this?
I'm afraid you've frozen, looks like.
Does it look okay?
It looks okay now. Yes, now I can hear you.
How about, okay, how about this? I might computer. Okay, let's try this one more time. Okay, can you hear?
I can hear you.
Can you hear me now?
I can hear you.
Oh, good. Okay, I think we might be good.
Recording in progress.
Okay, can we start? How about now?
Yeah, the screen sharing is about to start. There we go.
Okay, good. So, thank you for that kind introduction. Let me know if you have trouble hearing me, because I'm using a phone and a computer. And we're going to talk about total avoidance of perioperative transfusion beyond a scientific possible. At Johns Hopkins now for about 12 years, and I'm going to share with you our experience. My disclosures, I am on an advisory board for Haemonetics, and I've been on several committees for professional societies. Objectives, we're going to talk about Jehovah's Witness patients and why they believe they should avoid transfusions. We're going to talk about important methods used to avoid transfusions. And we'll talk about the outcomes and costs and how we use informatics to look at treatment plans and outcomes. So first, who are we talking about? Who are these patients that can't be transfused? Well, about 90% of the patients who can't be transfused are for personal or religious reasons. For example, Jehovah's Witness patients. The other 10% are those with multiple alloantibodies, like sickle cell patients who are frequently transfused, or for places where no blood is available. Can you guys still hear me and see the slides?
The slides have disappeared, and I don't know whether you were advancing the slides. We just saw the introductory slide.
Okay, I might need Nathaniel or someone to show my slides for me, because I'm at a place where I don't have good internet except for my phone. So I did send Nathaniel my slides if he doesn't mind sharing them.
The good news is we're about 5 minutes ahead of time, so everybody just remain patient, and we'll get Dr. Frank's slides going here and his talk.
Okay.
Yeah.
I just unshared, and I bet you can hear me fine, but I do need help with the slides
But
because my
mostly,
internet.
occasionally the audio is breaking up a little bit. But by and large, we can hear you pretty well.
Okay, I'm going to a better spot.
Yes, we may have to sit on top of a Wi-Fi router or something.
Please just give us a minute.
Hi, Nathaniel.
Hi,
Do
Steve.
you have the slides I sent
Yes,
you
I
as a
do.
backup?
I do. I'm just trying to
Good.
get it up now. Thank
Oh,
you.
good. I will make this talk worthwhile as soon as we get going.
One of the advantages of being a cardiac anesthesiologist is you're used to staying calm when things are not going well.
That is true. Cool under pressure. That's our motto.
In the meantime, Neil, I wonder whether you could take some of the questions, if some questions that were addressed to the other speakers.
Sure. Well, perhaps while we're waiting, we can go ahead with some of the first questions that are in the chat or the Q&A section. And then as soon as the slides come on, we'll go back to Dr. Frank. So I think this first question might be directed to Dr. Simitu. So the question is regarding the case reports from Calabar University in Nigeria. So you mentioned the problem of general doctors who might not necessarily know the anatomy of the organ on which they are operating. I wonder if you can comment on what maybe some of the biggest challenges or barriers to bloodless care might be in developing countries. Is it related to education, the challenge of providers having to be generalists and not necessarily experts in which they are operating? Dr. Simitu, can you comment on that?
Yes, thank you. I think the main challenge is that the doctors operating are generalists, they are not specialists, and they are working in the countryside where even the equipment is not enough. So if someone is just a generalist, they are operating, let's say, a cesarean section, they are not well versed with the anatomy and the techniques. So they tend to rush in operating, so the patient bleeds a lot. So the cesarean sections are one of the commonest operations being done in the countryside with a high fertility rate. So most of the generalists doing major operations, especially in emergencies, patients tend to bleed a lot. We will need to refocus the training so that when they are doing their internship, they are well trained how to do some of these operations to avoid bleeding too much. And that can help to improve the technique in carrying out the surgeries.
Terrific. Thank you very much for that. I wonder if I can go back. We've got a couple of other questions in the chat, but I wanted to bring a question to Dr. Trentino. It was really interesting in your presentation to see how there can be an enormous amount of confusion and perhaps resistance to bloodless and PBM practice when even healthcare providers, not even the general public, don't understand or trust what we're seeing in studies when we wind up seeing, conflicting results. So how do you see this being addressed, helping everybody to understand data and trust in the science that we're seeing?
It's a really good question, because some of those issues that we talked about, where we've got individuals, we've even got research, or editorials, commentaries that are constantly trying to compare the results of randomized control trials that are simply comparing to hemoglobin strategies to observational studies that are comparing transfused to non-transfused. That incorrect comparison, I mean, that's been happening for decades, and we've published a lot to try to counteract that. It doesn't seem to be working at this stage. So your question's a very good one. What more can we do? I think it is a matter of more education and more studies. I think as we get more and more big data studies published, that will make a big difference. The other thing is there is more of a movement in recent times to use causal inference methods in statistics, where we set up studies in a robust way and we're able to draw causal conclusions. So that certainly is a movement worth keeping an eye on and seeing what impact that can have. I'd be happy to hear if you've got any suggestions as to what might work in your part of the world, because it's certainly an uphill battle for sure.
Dr. Trentino, one of the things I was fascinated about in your talk was, reaching back, as you and others have done, to the Bradford Hill causation criteria, which really have withstood the test of time in many ways. Looks like we're about to get the slides up. But in any case, the relationship between transfusion and postoperative infection shows epidemiologically a 7-fold increase, which is the third largest effect in public health after smoking and lung cancer, 20-fold, and smoking and cardiovascular disease, 10-fold. And so I've tried to use that. I don't know if I'm convincing anyone. The transfusion medicine community has certain cult-like feelings about defending their dogma, I'm afraid. And I say that as a transfusion medicine physician. So it looks like we got the slides up. So Dr. Frank, take it away. I think you may have to tell us when to change the slides.
Yeah, Steve, please start from the beginning.
Yeah, hi, Nate. Thank you for finding the slides. Thanks, Neil, for the handoff and the introduction. I think you can hear me and see me now, I hope. So we're going to talk about bloodless medicine and total avoidance of perioperative transfusions. And we're going to also focus on how we use informatics. Next slide. All right, so here's my disclosures. A few committees and advisory board for Hemonetics, who makes TEG and cell savers. Next slide. Here's our objectives. We're going to talk about Jehovah's Witness patients and why they believe they should avoid transfusions. We'll talk about important methods we use to optimize patient blood management and to avoid transfusions. And then also, how do we look at outcomes and costs in terms of bloodless medicine and informatics? Next slide. So who are these patients who can't be transfused? Well, in our institution, about 90% of them have personal or religious reasons why they decline transfusions, and most of them are Jehovah's Witness patients. The other 10% are those with multiple alloantibodies, where it's very difficult to cross-match, or in areas where blood is not available, such as remote or austere locations. Next slide. So where do the Jehovah's Witnesses get these ideas they need to avoid transfusion? Well, these are the three places in the Bible where their version of the scriptures say that you should not consume blood. They even say you should not eat blood, shall abstain from blood. And I always thought this was fascinating because I think this is the same place in the Bible where kosher Jewish food and halal Muslim food believe you should drain the blood out of the animal before it is slaughtered. So I really think these all come from the same place. Next slide. So we used to think the Jehovah's Witnesses were kind of crazy until 1984, because you can see on this timeline, next slide, it's going to show an arrow. That 1984 was the absolute worst year to have a transfusion because hepatitis C in the red line and HIV in the green line were actually it was the worst year to have a transfusion because neither one of these viruses was being tested in 85 when the HIV test came out. And it wasn't until 1990 when the hepatitis C test came out. And you can see the blood was very unsafe even up until about the year 2000 when it got safer. Next slide. So in terms of Jehovah's Witnesses, a lot of physicians get confused when they don't know their beliefs. And I tried to simplify it in this slide, which was taken from jw.org. And I tell my friends at work that Jehovah's Witnesses do not accept red cells, plasma, or platelets. I call those the big three. And they also don't accept whole blood or white cells, which are pretty rarely used, except whole blood is making a comeback in trauma. But in the green arrows, these are considered personal choices, and each person must decide for themselves whether they accept things like albumin or cryoprecipitate, which are derived from human blood donors, and also PCC, prothrombin complex concentrate, which is rich in 2, 7, 9, and 10. And then there's also these blood substitution substitutes called hemoglobin-based oxygen carriers, which have not made the market yet because they haven't been FDA approved. And there's one called HemoPure or HBOC 201, which is a personal choice. Next slide. So we've had a program since 2012 at Johns Hopkins for patients who don't accept transfusions. And what I'd like to say is bloodless medicine and surgery programs have a lot in common with patient blood management programs. Next slide. And you can see there's a lot of overlapping principles that I'm going to go through one by one. For either reducing transfusion completely in a bloodless program. And we'll go through what they share in common in the next few slides. Next slide. So we talk about optimizing red cell mass or treating pre-op anemia. I'm a cyclist myself. One of my heroes was Lance Armstrong. His drug of choice was erythropoietin. And I use this to demonstrate the importance of treating pre-op anemia because I tell our patients, hey, we might give you this drug that the Olympic athletes use, but for you, it'll be legal. It turns out, though, we give a lot more iron than we do erythropoietin because the most common cause of anemia worldwide, and even in the United States, is iron deficiency. Next slide. So oral iron is effective, but relatively poorly absorbed. Only about 10% of oral iron is absorbed. And some people claim there's side effects like cramping or bloating in the GI tract. I personally take oral iron every time I donate blood, and I don't have those side effects. But because of oral iron side effects and the poor absorption, we often go to intravenous iron. And here are the 6 different IV iron compounds that are available in the US right now. We tend to use the iron sucrose for inpatients because it's the least expensive. And we use iron dextran or Infed for outpatients, the low molecular weight iron dextran on the left, because we can give a whole gram in one visit, and the cost is only about $280, whereas some of these other compounds can be as much as 10 times more expensive. Next slide. So at our institution, we have what I call the erythropoietic order set in EPIC. The real name for it is a blood refusal medications order set, and that's how you find it in EPIC. And it gives the doses, the routes, the frequency, and the duration of treatment for everyone who is not familiar with these medications, which is 90% of the doctors and nurses on the floors. We put this into a neat order set. And sometimes we modify these doses. For example, we've gone up to 40,000 units of erythropoietin twice a day for patients with severe anemia. And note that we give our erythropoietin intravenously because we think it's more effective than subcutaneously. Next slide. So when you talk about treating pre-op anemia, we came up with a novel algorithm that tells you the optimal target hemoglobin that you need before surgery to avoid transfusion. And what we did is we took the allowable blood loss formula that we learned in anesthesiology, and we algebraically solved it for pre-op hemoglobin. And I'll show you how that works on the next slide. So this is the classic allowable blood loss formula that we learn in anesthesia as residents. ABL is allowable blood loss. EBV is estimated blood volume. And then you have pre-op and post-op hemoglobins. So we solved it algebraically for the pre-op target hemoglobin. And this is what you come up, and I can explain this better with the picture on the next slide. Okay, so when you put the numbers into the formula, this is what you get. On the x-axis is the patient's body mass in kilograms, because larger patients have a larger allowable blood loss, because they have larger blood volumes. On the y-axis is the target pre-op hemoglobin you need to avoid a transfusion. So for example, in the yellow line, with an estimated blood loss of 1,000 mLs, if you're a 100-kilo patient, you need a pre-op hemoglobin of about 9. See the yellow 8-kilo patient losing that same 1,000 mLs of blood, you need a target pre-op hemoglobin of about 11. So this is pretty much what we use now to calculate the goal hemoglobin before surgery in patients who don't accept transfusions. Next slide. So we had a review article 3 years ago in anesthesiology on how to manage patients for whom transfusion is not an option. Next slide. And in table 1 in this paper, we talk about pre-op, intra-op, and post-operative interventions. We're going to go through these one by one. We already talked about treating pre-op anemia, managing iron deficiency. It's also important to discontinue anticoagulants. That seems obvious, but there's so many anticoagulants nowadays that the guidelines are sometimes hard to follow. Intraoperatively, we can do simple things like maintaining normothermia to reduce bleeding, controlled hypotension, especially for orthopedic, closer to 70 compared to antifibrinolytics like tranexamic acid. A gram of tranexamic acid costs about $20. It's now being used, we call it a game changer in the blood management world, because it reduces bleeding and transfusion by about 30%. If you look at all the studies on tranexamic acid. Meticulous surgical technique, we'll talk about that in a minute. But let's talk about post-operative. We can decrease phlebotomy by number of blood draws and the size of the phlebotomy tubes. I'll show you those tubes in a minute. We can tolerate lower hemoglobin levels because patients do fine with hemoglobins below adapted to those hemoglobins. Next slide. Okay, so of these methods in the table, about 12 of them involve what I call keeping the blood in the patient, or reducing blood loss. Next. Does it go forward? Okay, yeah. So these 12
We've lost your audio, Steve.
Looks like Dr. Frank might have logged out, and so hopefully he'll log back in order to get a better connection. Perhaps we'll hear from him in a minute. Maybe we could go ahead with a few more questions until he comes back, if that sounds all right with everyone. We can move on to one of the next questions that I see in the chat. And I think that this could probably be answered by a number of people on our panel. It was directed towards Dr. Simotu regarding that second scenario, that patient scenario of hemoglobin dropping to as low as 1.8 grams per deciliter. Can you comment on what other remedy was given in that situation, apart from fluids and oxygen? And I can imagine that a number of other folks on the panel can likely comment on medications that can be used to boost low hemoglobin at that point. Dr. Simotu, can we start with you?
Thank you very much. I think from that presentation, I remember Nathaniel presented, they gave fluids, they gave dextran, and the patient was actually intubated in ICU and was also started on erythropoietin. And with time, the HB started improving. The patient was on oxygen, intubated in ICU. So the IV fluids, the inotropic drugs to maintain the blood pressure, and then you initially start as well giving erythropoietin. So that is slowly improve the HB. I think if Nathaniel can actually comment more on what he managed the patient.
Dr. Osoro, would you like to comment on that too?
Yes, I'd like to. Please, could you repeat the question?
Sure. It was related to one of the case studies that was shared in Dr. Simitu's lecture about that case of a hemoglobin dropping so severely to as low as 1.8 grams per deciliter. Dr. Simitu had talked about fluids and oxygen, and when the hemoglobin is so low, other medications that can be used to be treated. So Dr. Simitu talked about EPO and iron, and I wonder if there are any other specifics to be added to that.
So that was a case of acute anemia, severe blood loss. So the key thing is the hemodynamic status, because that's what kills the patient urgently. So we had to stabilize the patient hemodynamically. Of course, yeah, so we started with the crystalloids and we moved on to colloids. But because the bleeding wouldn't stop in this obstetric case, patient ended up in theater and had to have a hysterectomy because there was uterine ectomy due to some huge fibroids. So after the hysterectomy, the patient was basically hemodynamically stable. But the challenge came with things that would accompany such a terrible hemorrhage, acidosis, some acid-base imbalances. So that had to be corrected. And of course, we know that more and more using saline a lot have contributed to that acidosis. There was also hypernatremia, hyperchloremia. So we had to change the fluid to 4.3%. dextrose in 1/5 saline. So these are things that we needed to take care of. There was no issue with infection or anything like that. But once the patient was stable, the main issue was then raising the hemoglobin. And that was done with IV iron and erythropoietin. Chris, I don't know whether I've been able to address the question.
Yes, you've answered quite well. Thank you very much.
Okay, thank you. I think Steve is back.
And Nathaniel, it's if you could show those slides, I could finish in about 10 minutes. Oh, beautiful.
Wonderful, thank you.
Oh my God, this is great. Thank you. So, like I said, 12 of these 16 methods involve keeping the blood in the patient. Minimally invasive robotic approaches, normal thermia, controlled hypotension, tranexamic acid, and next slide. Here we go. So we talk about meticulous surgical technique. And so I made this graph to illustrate what that means. I like to say that blood loss is indirectly proportional to how hard the surgeons try, because when they try harder, they lose less blood. I learned this, for example, we do a lot of Whipple surgeries for pancreatic cancer. Every time I bring in a patient for a Whipple, the surgeons will lose about half as much blood if the patient was a Jehovah's Witness. So they either tie off bleeders, or they just take their time, or they don't let the intern do the anastomosis, but they definitely can reduce bleeding if they try harder. Next slide. So what about temperature and hypothermia? It turns out that even mild hypothermia during surgery, even by 1 degree centigrade of hypothermia, can increase bleeding by 16%. And this is from a meta-analysis. We used to think at 35 degrees, patients bleed more, but now we see that even at 36 degrees, patients bleed more. Next slide. So this is the meta-analysis by Dan Sessler and his group, showing that even with mild hypothermia at 36 degrees centigrade, there was a 22% increase in the risk of transfusion. So aggressive warming during surgery is something we recommend for patients who don't accept blood. Next slide. So what about cell salvage or the cell saver? A lot of people that don't work in the operating room, they don't even know what this looks like, but here is an example of a cell saver. Cell savers came out in the late 1970s, just in time for the HIV crisis in the blood supply in the 1980s. So everybody wanted cell saver blood back then. And I still haven't met a patient yet that wouldn't rather have their own blood back compared to someone else's blood from the blood bank. Next slide. So we looked at the quality of cell saver blood by looking at 2,3-DPG concentrations. And the cell saver blood in green had normal 2,3-DPG concentrations, the same as pre-op fresh patient blood shown in dark blue. But stored blood or banked blood about 90% depleted in 2,3-DPG. And that happens after about one or bank blood is left shifted. And we had a co-oximeter in our lab. Can we do the next slide? There we go. So stored blood or banked blood is left shifted. meaning it has more difficulty offloading oxygen at the tissue levels. But fresh blood and cell saver blood were identical because cell saver blood's only been outside your body for a couple hours, as opposed to banked blood, which we store for up to 6 weeks. Next slide. So our paper was written up in the media about the higher quality of cell saver blood compared to banked blood. And they said we recycle a lot of things like paper, plastic, and metal, but we can also recycle blood and give patients back their own blood during surgery using cell savers. Next slide. So it must have been a slow week in the media because even the New York Times chose our small study to talk about the benefits of giving patients back their own blood during surgery and how we think that cell saver blood is higher quality than banked blood because of the 2,3-DPG levels, but also because the cell membranes are more deformable, and the cell saver blood doesn't have the storage lesions that develop in banked blood. Next slide. So what about phlebotomy blood loss? We talk about keeping the blood in the patient. And we took a survey in the 5 adult ICUs at Johns Hopkins. It turns out that 60 mLs a day on average were removed from the patient for phlebotomy, which is about 1% of your 5-liter blood volume, which is how much erythropoiesis you have every day. You destroy and create about 1% of your blood cells. So this is a lot of blood we're sending to the lab. And in the neurocritical care unit, they use this inline device to reduce the wasted discard. Next slide. And we have switched the entire hospital at Johns Hopkins to the pediatric size tubes shown in the middle that hold between 2 and 4 mLs. We hardly ever use the adult size tubes that hold 5 to 10 mLs. And for special patients like Jehovah's Witnesses, we'll use these tiny little neonatal tubes that hold 0.5 mLs or 1/20th of the blood that's in the large adult tube. Next slide. So what about tranexamic acid? It's being called the game changer now in the orthopedic world. We started using it in hip and knee replacements, and we saw this dramatic decrease in red cell transfusion rate. We also hired 4 new surgeons at the time and 2 large showing less is more for transfusion. But nonetheless, tranexamic acid has been around for 50 years, but only in the last decade are we using it now to reduce bleeding and transfusion. Next slide. So like I said, there's 2 artificial blood substitutes that tried to come on the market. Sanguinate failed, is no longer available. Hemopure is still trying to come on the market. It's a bovine hemoglobin that's been polymerized and cross-linked. It has a very high P50, so a right-shifted curve for hemoglobin oxygen saturation. And it causes nitric oxide scavenging and some vasoconstriction. And if you give too much of it, you can get methemoglobinemia. So it's still not FDA approved, but we have used it for compassionate use in some Jehovah's Witness patients. Next slide. So what about legal activity around patients who decline transfusion? This was a case in Philadelphia, a cesarean section patient who died after bleeding from postpartum hemorrhage. And it turns out that even though she signed the consent that she didn't want blood, there was a lawsuit anyway. And what these cases boil down to, for the most part, is recognizing the hemorrhage quickly and taking the patient back to surgery to stop the bleed without delay. And that's how physicians and nurses can be liable for a case like this if you don't recognize and treat the bleeding in a timely fashion. Next slide. So we looked at over 1,000 patients in our bloodless medicine program and their outcomes compared to patients who accept transfusion. Next slide. So we looked at a group of 1,000 bloodless patients, compared them to matched controls. We used ICD-10 codes to look at morbid events in the hospital. And when we looked at ischemic events like stroke and heart attack, there was no difference. Respiratory events, renal dysfunction, thrombotic events, no difference. But we did find less infection. That's hospital-acquired infection in the bloodless patients. And I believe this is a true benefit to bloodless care, because Neil Blumberg and his group in Rochester have clearly showed, even in a meta-analysis of randomized trials, that banked blood can predispose patients to hospital-acquired infection. And if you can avoid banked blood, you can reduce infection. Next slide. We also look at cost and care, and these are medians and interquartile range. We found 8 to 9% lower cost with the bloodless care. So what we're doing for these patients not only improves outcome by reducing infection, but also saves cost because blood is expensive, and so are hospital-acquired infections. Next slide. So GI bleeds are something we see quite often. And we took a series of patients who came in for GI bleeding who declined transfusion, and we mapped out their first, lowest, and last hemoglobins. And we had 10 patients with nadir hemoglobins less than 5, and only one of them died. The threshold of 5 grams per deciliter used to be of a threshold for increased mortality. But with modern care and aggressive treatment, like we've described, we only have 1 death out of 10 with nadir hemoglobins less than 5. Next slide. And I got permission from this patient to take his picture with his wife. He had a GI bleed about a year ago, came in with a nadir hemoglobin at 2.1. The medicine served in palliative care because they were convinced that he was going to die, and he was adamant about not taking transfusions. So they put him in the ICU, and we gave him aggressive treatment with tranexamic acid, a high dose erythropoietin, even added darbepoetin as a second erythropoietic medication, iron, folate, B12, and we totally minimized phlebotomy. And guess what? He went home on day 17 with a hemoglobin of 5.7, and he really surprised all of us. Next slide. This is his hemoglobin trend. You can see there were multiple days where we didn't even draw blood to measure his hemoglobin, but we did treat him aggressively with those erythropoietic medications. Next slide. So what about pediatric patients who belong to families of Jehovah's Witnesses? This has been a really hard ethical dilemma because at least in the United States, parents are not allowed to refuse life-saving therapy for their children. Next slide. So we took about 200 children of Jehovah's Witness families in our bloodless medicine program. And we found that in these 200 children, we had no mortalities. We had no court orders because we avoided that. And only 6% of the pediatric patients received any allogeneic transfusion. What we tell the families is we'll do everything we can to avoid blood. And we tell them those methods like tranexamic acid, cell savers, erythropoietin, keeping your child warm during surgery. We tell them all these things we're going to do to reduce or avoid transfusion. And then we tell them if their child's life is threatened, we're legally obligated to give them blood. And it turns out 6% of those patients got some allogeneic blood. Next slide. And in fact, in these pediatric patients, they did as well or better, shown in blue, compared to standard care patients in red, because mortality was 0 and composite morbidity on the left was significantly lower in the bloodless group. Next slide. We're almost done. Sorry to run over. But we looked at 10 years of our comprehensive patient blood management program. And we looked at the cost-benefit ratio, and we found that we had a 7.5-fold return on investment for our PBM program with equivalent or improved outcomes. Next slide. So on the left, we show 10 years of blood utilization with a $3 million decrease in annual blood spend. We went from $27 million to $24 million a year. So that's about a $3 million cost savings. And then on the right side are the revenue brought in by Jehovah's Witness patients. In the yellow line is the net margin, and we're bringing in about $5 million a year in margin to Johns Hopkins Hospital by taking care of our Jehovah's Witness patients. So that's an $8 million a year benefit for the hospital, which is a 7.5-fold return on investment. Next slide. So I never thought this would happen when we started our bloodless program in 2012. But we've had now 13 publications on that last slide in the last 10 years. So 13 publications on bloodless medicine, everywhere from review articles to case series with outcomes. And I never thought this area would be so fruitful, but we're learning lessons from patients who decline transfusions that allow us to reduce blood utilization in all of our other patients. Next slide. And this is my last slide. Pressure patients, prayer, proline, plasma, and platelets. This is our most famous surgeon who's done over 3,000 Whipple surgeries at Johns Hopkins. Of course, when patients decline transfusion, we might not use plasma and platelets, but nonetheless, I like this algorithm. Next slide, I think that's it. Thanks for
Terrific.
bearing with my poor internet connection, and thanks for showing the slides, Nathaniel.
Wonderful. Thank you so much, Dr. Frank. I'm so glad that you were able to hang in there with the technical troubles to be able to share your presentation. That is some impressive stuff. And I think that your 6 Ps and that slide where you showed the photo of that gentleman and that broad cocktail that you had utilized was a great answer to that other question. You know, what can you do? What kind of interventions can help manage hemoglobin when it gets specifically low? You've definitely shown that there are a lot of tools in the toolbox that can be used there. So we've got a few minutes for questions, and so I just wanted to ask for our speakers and our panelists, for whatever questions we don't manage to answer, can you take a look at the Q&A section and type in the answers to those questions that we don't manage to answer? So first of all, I'll kick things off. There was a great question that started out with in line with various government laws that ought to protect the rights of patients to decline transfusion if they don't want it in their care. But however, many hospitals and doctors might ignore this, and we wind up seeing patients' rights not being respected. So, you know, when I think, Dr. Frank, about the examples that you've shared in the past of how you've used data, those fantastic posters placed on bathroom walls and everywhere showing transfusion data among the surgeons and the anesthesiologist, what are some of the keys to changing culture and attitudes that can help advance this work and not cause patients to be ignored?
I can take the first try at that question. Thanks, Becky. I think running the 2 programs side by side, the patient blood management program and the Bloodless program, really they feed off each other, because you, like I said, until you see patients with hemoglobins of 4 or 5, and you see them walking out the hospital door, we never did that before, because we were trained that you have to give blood. Hemoglobin is 7, you have to give blood. But now we're learning lessons from patients who don't accept transfusion, that we can go much lower than 7, and 9 times out of 10, the patients do fine, even down to hemoglobins of 5. And that's why I hear all my friends running Bloodless programs, they always want to tell the story about their lowest hemoglobin patient and how surprised they were that they did okay.
Are there any other comments from the panelists about that comment too, about options to address attitudes and perspectives?
Just like to add to Dr. Frank's comment that in a paper many years ago in Lancet, vascular surgeon whose name is escaping me now, and Jeff Carson was one of the authors, showed that witness patients who refused transfusions actually had better outcomes than expected, and very low mortality rates. You know, we're keeping relearning these lessons, that the notion that there's some magical hemoglobin hematocrit at which we need to transfuse patients and they will do better is a total fabrication. It's a total historical dogma that has nothing to do with any facts in the history of medicine. There is no hemoglobin at which patients should be transfused and they will do better. It's a clinical judgment, and as Dr. Frank and many others have shown very eloquently, we can manage patients without using the hemoglobin as the main driver of decision making, because there's never been any evidence. It's only been expert opinion.
Perfect. Thank you for that. There's a great question about AI and bloodless medicine, and how can resource limited settings benefit from this? Are there organizations that can assist healthcare workers in places? The question asks whether there's help in specific places like Ghana. But I wonder if any of you, and maybe this is a good question for Kevin as well, about how resource limited areas can benefit from AI and data.
It's a very good question. I think probably the fastest answer is that technology changes so fast over time, and we see the costs dropping really quickly and the accessibility increasing really quickly. A lot of the things from a few years ago, which were a lot of technologies in terms of AI, machine learning, the software we used were considered to be cost prohibitive, but they're becoming increasingly accessible. I think other things as well is a lot of the research that we're doing in this space can be shared. It's not so much a matter of reinventing algorithms, reinventing things that we're doing, but just sharing tools and technology between us. So I don't think it's something that necessarily has to be an obstacle based on the resource setting that people are in. I think it's just something that through collaborations we'll be able to work towards.
Thank you. I think that there was
I think,
question.
Becky,
Sorry. Go ahead.
A lot of programs that are on the cutting edge are using dashboards for running patient blood management programs. In the US, hospitals are going to Epic so fast now. And the dashboards that people use are done in the business intelligence platform called Tableau. And we've been using Tableau now for about 8 years to generate reports that show transfusions that are either inside or outside guidelines for each individual physician compared to their peers. And so these reports really set up a friendly competition to do better. If you see that you have no transfusions out of guideline, but your peer has 20% of their transfusions out of guideline, it sets up a friendly competition to do better. And we've been sending out these reports with names on them. We started with numbers, and then you could find who you were compared to your peers. And then the chief of surgery said, Steve, you should put names on these graphs, not numbers. And then people will pay more attention. And so that's what we do now with our Tableau reports, is we have all the physicians' names. And then sometimes they get angry, like if they have too many out of guideline transfusions. And I say, oh, this is not morbidity or mortality or anything like that. It just shows that you give blood at a higher hemoglobin than your peers. Okay, so don't get all upset.
Yeah, I think that was very powerful. Hearing about your efforts in that way in the past, that was excellent. Due to where we are at time, we will end the Q&A section at this point. But as mentioned, I will ask our speakers and our panelists to please go to the Q&A section and type in answers to everyone's questions. And I will pass it back to Dr. Bloomberg to wrap up this section.
Consider the session wrapped. Thank you so much to our brilliant and incredibly insightful speakers, and to, of course, the panelists and the audience. We've had over 200 folks participating. This has been a great session. We'll move to the abstracts now. Thank you very much. And thank you, Rebecca, for your contributions as well. And I'm going to sign off now.
Hello?
We can hear you.
We can, okay. So are the only panelists joined at this point of time? Sorry, Nathaniel?
Yes, you can go ahead, please.
Okay, so good evening all. I've just come back from work, so just joined in the meeting. So welcome to the oral abstract session. My name is Dr. Prabhunes Sagikar. I'm a consultant GI and a pediatric cancer surgeon at Bangalore, India. So I've been associated with BMS for the last few years and a good friend of Nathaniel and the team. I've got my panelist, Dr. Tommy, who's meant to join. I'm not sure she's joined yet. Tommy, are you there?
She's having challenges with the network. She'll join eventually.
Okay, and Dr. Anima is there as well, or he's also off?
Yeah, I am.
Hi, good evening. So anyway, do you want to introduce yourself as a panelist for this oral abstract session?
Oh, okay. I am Maniema Itaisian from Nigeria, a nurse by profession, one of the moderators.
Okay, so I think we'll kick off the session anyway with the first oral abstract because Tommy was meant to come and introduce. I think she's stuck. So it's my pleasure to introduce the first speaker. Dr. Marshall Rosenberg is there?
Hi, yes, I'm here. Let me
Hi.
just share my screen. I can share the PowerPoint.
Good evening. So Dr. Marshall will be talking about should monitoring guidelines for IgM, MGUS, and decision to treat be different when caring for Jehovah's Witness. And just to give an introduction, Dr. Rosenberg is a PGI1 at Lancaster Medical Center, Vinewood, USA. The platform is yours.
No, thank you so much. It's my first year here, and I hope one of many. It's been wonderful to listen to the previous speakers, and just very happy to come here. So I will share my slides now. Let me know. I'm going to get this full screen. All right. Patients can see. Great. Okay, and you can see a full screen now for the slides?
Yeah,
yes,
we can. Yeah.
Perfect. Okay, let me just minimize that. Okay, so today, thank you so much for the introduction. I'm Marshall Rosenberg. I'm a PGY at Lincoln, and on behalf of myself, as well as the Hematology Oncology Group, the Bloodless Medicine Consulting Service, and the Pathology team, we just wanted to say thank you so much for having me here. Today, I'll be talking about should monitoring guidelines and decision to treat for IgM-MGUS be different when caring for Jehovah's Witnesses? And this really came about when we had a case that a patient came in who was a patient studying to become a Jehovah's Witness, came in back in July. And so after treating this patient, it really made us think about these monitoring guidelines, and so which I'll go into in a bit more detail. The first thing I wanted to talk about was defining what is MGUS. And this is where you have monoclonal gammopathy of undetermined significance. And this is where plasma cells in your bone marrow oversecrete one of the immunoglobulins. It can be IgM, IgG, IgA, etc. And so it's relatively common. 5% of adults over 70 have some form of MGUS. And while there's many definitions for IgM MGUS, I use the Mayo Clinic's definition that you have an IgM protein in your serum less than 30 grams per liter, and less than 10% of your plasma cells are over-secreting that IgM protein. And I'll go into the symptoms and signs in a moment, but just realize that these patients are completely asymptomatic, walking around, may not even know they have this. Now, this specific gammopathy, IgM, can progress to Waldenstrom's macroglobulinemia, which is a bone marrow malignancy, most commonly, as well as it can also cause AL amyloidosis and rarely multiple myeloma, as that's typically an IgG pathway. It itself carries a higher relative progression risk to malignancy, closer to 2% per year compared to 1% per year for the other gammopathies. In addition, it has causes itself to increase risk of hyperviscosity syndrome. Now, this is because IgM itself is a bulky pentameter protein, and so it binds to itself as well as platelets. And so patients will most commonly exhibit bleeding, but they can also cause thrombotic events and end organ damage shown as ischemia. So once a patient has IgM-MGUS that progresses to hyperviscosity syndrome, that itself is already a decision to treat with an oncologic emergency. When it comes to monitoring and decision to treat, the International Myeloma Working Group states that their monitoring ranges every 6 months to the first year and then expands to 3 years. And these are for patients, again, walking around asymptomatic. And these symptoms can be signs of a malignancy, such as fatigue, anemia, weight loss, bleeding, organomegaly, and signs of cryoglobulinemia, which would be neuropathy and rashes. In addition, the signs that we look for would see confirmed anemia, creatinine, calcium, and serum urine protein levels that change. And so these are really the major monitoring guidelines that we use today. And when it comes to decision to treat, ultimately it comes down to the clinician and patient, but we use different models to help the clinician and patient decide when to start treatment. And so the Mayo-MGUS risk stratification model separates patients into different buckets, whether they're low, intermediate, and high risk. And this corresponds to 5, 20, and 60% 20-year progression risk. So this is a very slow process, not typically occurring in a short period of time. And so we use M protein levels above 1.5 grams, a kappa to lambda free light chain ratio above 1.65, and the presence of non-IgG MGUS traits. And so the patient that I'm about to speak with was someone with IgM MGUS. So she already falls into an intermediate category based solely on that. But as we go through, we'll see more and more how she's really a high-risk patient. And so I'm going to walk us through this case together. A patient becoming a Jehovah's Witness presented to our ED with anemia and blurry vision. She has documented IgM-MGUS and CLL, and she came in for 6 weeks of worsening blurry vision, fatigue, shortness of breath, and an outpatient hemoglobin of 5. Now, 11 months prior to admission, she was recently changed from a 6-month monitoring schedule to an annual checkup by remaining symptom-free with low circulating protein levels decreasing from 2020. And in the ED, her fecal occult blood test was positive. So we knew she was bleeding somewhere, most likely in the GI tract. And as I walk down these values, from the top, you can see her hemoglobin. She came in severely anemic at 4.8. She had a normocytic anemia. And as we walk down, you can really see that she was coagulopathic. Her bleeding times were all prolonged. Her PT, PTT, and INR were all prolonged, as well as low normal iron saturation and ferritin levels. And in addition, what was interesting is when you see her hemolysis labs, you can see that she's having an inadequate response to this anemia. We really wish she's seeing a higher reticulocyte count, higher index, showing that your body's trying to produce more red blood cells. And in her case, we were having that inadequate response, which points us towards a bone marrow issue, but also a severe bleeding. And so while she was admitted for a GI workup for a colonoscopy and endoscopy, but unfortunately our colleagues weren't feeling safe enough to perform the procedure unless we helped correct her anemia. And so at this point, we consulted our Bloodless Medicine consulting service, which is relatively new at our hospital. It's only been between 2 and 3 years in the making. And so this was really exciting for them to be able to come speak with a patient. And together they decided that she would only accept plasmapheresis, but only with albumin, with no blood products other than plasmapheresis. And so we had that conversation and then began to treat her anemia with supportive measures, IV iron, B12, folate, and 20,000 units of EPO 3 times weekly. And while this was happening, we also obtained a peripheral smear. And as you can see on the right-hand side, this is her smear at a 10x slide. And you can see in these blue rectangles, all these rouleau formations. This is showing that there is some protein that's binding to each other on the tops of these red blood cells. And so that's really what led us down this immunologic workup. And from there, back onto the left-hand side, we saw that there was a concentration of 5.89 grams of IgM kappa protein. In addition, she had immunoglobulin levels in her serum of 8.7 grams per deciliter and an elevated beta-2 microglobulin of 4.56. When we looked at her serum free light chain analysis, we saw that she had a kappa protein of 115, a lambda protein of 5.3 with an elevated kappa to lambda ratio of 21. And now going back to that Mayo MGUS model, you can see that she's really checked all the boxes for that high risk progression. She has a concentration above 1.5. She has a high ratio above to now to 21, which is extraordinary high. In addition, she has IgM MGUS versus IgG. And so she's checking all those boxes, which made us really worried about this patient. And so for the next 6 days, we really were focusing on trying to optimize her anemia so she can get this procedure. And at that point, we realized that the patient was inactive hyperviscosity syndrome. This is where we saw that she had worsening blurry vision on day 7. And so CT and MRI were both negative for acute abnormalities. However, a fundoscopy exam showed that she had dot blot hemorrhages, papilledema, and showing an acute increase in intracranial pressure. And so when we saw her viscosity level come back, it came back to 7.9, which is the highest we've ever seen at the hospital, a reference range of 1.5 to 1.9, showing that she was having an oncologic emergency. And so the treatment that's category 1 for this condition is plasma exchange. And because we spoke with her earlier, she was accepting of plasma exchange as a practicing Jehovah's Witness at this point. And so we were able to transfuse her with albumin at a rate of 40 mils per kg for her volume replacement. And after 3 sessions, the patient really started to improve. She had improvement of her blurry vision, her viscosity decreased, her hemoglobin rose to 6.9, and her PT, PTT, and INR all began to normalize. On day 16, her bone marrow biopsy results showed a population of kappa-restricted lymphoplasmacytic cells comprising approximately 30% of her marrow. And so at this point, this really has led us towards the path of IgM MGUS transforming to Waldenstrom's macroglobulinemia. And at that point, she was discharged to begin treatment with Cytoxan, Darzalex, and Velcade for her newfound macroglobulinemia. And so as I finish up on these last 2 slides, really what we saw from this patient was it's unfortunate, but we missed that transition period. This patient was switched from a 6-month to a 12-month checkup because she was doing so well. However, we realized that for patients with asymptomatic MGUS, especially patients who are at such high risk of becoming anemic, we really need to continue the standard of care of a CBC, look at her blood, look at her metabolites, and look at these protein levels, but also make sure we have a standard 6-month follow-up visit. In addition, we want to have iron studies and coagulation labs because they could be an early warning sign, a slight red flag that can tell us that something's going on with her platelets at these visits, which would allow us to really check to see maybe they would benefit from an earlier treatment initiation. In addition, for special patient populations who have already progressed to Waldenstrom's macroglobulinemia, they're at a higher risk of becoming anemic for a very interesting reason. And it's a bit newer, and they haven't had so much research on this yet, and it hasn't impacted the guidelines. But Waldenstrom's macroglobulinemia patients have an increased level of hepcidin because it's a byproduct of the lymphoplasmacytic cells. And this causes patients to have refractory oral absorption of iron. And the reason is that it binds ferroportin, not allowing iron to then escape the gut. And so this is specifically important for patients who may not accept blood products like Jehovah's Witnesses. We really need to be careful and monitor their anemia and their anemic status, because it means they need IV iron rather than oral iron. And so just to summarize, really this case reinforced the idea that patient populations who may not accept blood products, they have this increased risk of anemia, thrombocytopenia, amyloidosis, and cryoglobulinemia, all points towards that we really need to be carefully monitoring them. And so these patients should, from the get-go, be considered at increased risk for complications. And so from what I saw with my colleagues, that we really want to focus on having more monitoring for these patients and signs for anemia, and then discuss earlier treatment initiation. And so thank you so much for having me here today, and I'm happy to answer any and all questions to the best of my ability.
Hi, Dr. Marshall. That was a very good presentation on your first on this platform. Unfortunately, I'm a cancer surgeon, so some of this go over my head, so I'm not in a position to ask you any questions. Anyone from the panelists who are in this field would like to ask any questions to Dr. Marshall, then please go ahead. I think, Marshall, you left everybody, were spellbound. I don't think they're coming with any questions, but great presentation. As I said, it's a good platform to discuss all these initiatives and projects. And I'd like to be on the whole presentation until somebody asks a question, then I'll get it back to you. Is it okay? Good. So from that point, we'll go to the second presenter of today's session. Kenneth Inakwa, are you there? Good evening, Kenneth. So Dr. Kenneth is a consultant chemical pathology. He works in the Department of Pathology Immunology at University of Calabar. He's going to talk us about bloodless management of an extreme life-threatening anemia due to heavy menstrual bleeding from a cervical polyp, a case report. Kenneth, over to you.
Thank you very much. Good everyone. So let me start by sharing the screen. Please confirm that you can see my screen.
Yeah, screen is seen. Just the volume can slightly increase, Kenneth, if that's possible.
Is it okay now?
Slightly better, yeah.
All right. So good day, everyone, and I'm going to present bloodless management of extreme life-threatening anemia due to from the cervical polyp. It's just a case report. So this is the outline I'm going to use. Then, so menstrual blood flow, as we know, is a critical physiological process that ensures that the fertility of the woman of reproductive age is preserved. And as we know, the normal menstrual cycle is expected to last for 2 to 7 days, with blood loss of less than 80 ml per second. So heavy menstrual bleeding is a common health problem affecting women of reproductive age and is defined as a regular but unusually prolonged menstrual cycle with blood flow in excess of 80 ml per second. Data on the prevalence is scarce, but an internet survey conducted in 5 European countries in 2012 reported that 27% of the 4,506 women who responded had 2 or more predefined symptoms which were consistent with heavy menstrual bleeding. And a review of primary care records on heavy menstrual bleeding in the Netherlands, spanning between 2004 to 2013, reported an average annual incidence of, let me see, of 9.3%. Sorry, 9.3 per 100% years. And the 95% confidence interval was 10.2 per 100% years. In Nigeria, heavy menstrual bleeding accounted for 57.4% of all menstrual disorders assessed among adolescents. Factors associated with heavy menstrual bleeding are hormonal contraceptives, presence of clots in menstrual blood, presence of uterine pathology like fibroid polyp or adenomyosis, and of course, anemia. Other factors like ovulation defect, ovulation or ovulatory dysfunction, endometrial, iatrogenic, and some yet to identify factors are associated with abnormal uterine bleeding. Heavy menstrual bleeding may be somewhat difficult to diagnose solely by quantifying the amount of blood loss. However, a good history, physical examination, laboratory and imaging tests will aid in arriving at a diagnosis. But the presence of blood clots and menstrual or menstruation of more than 7 days duration are independent because of menstrual bleeding. Anemia is also a common symptom among women with menstrual bleeding, and its presence gives more evidence of excessive blood loss. Here we report a case of heavy menstrual bleeding with life-threatening anemia in an unmarried woman of childbearing age. So the case, she was a 33-year-old para 0+1 lady who presented with bleeding from the lower genital tract for 4 days duration following the onset of menstruation. There was a 4-year history of abdominal swelling and menorrhagia of the same duration. The abdominal swelling was progressively increasing in size with associated abdominal pain. There was no history of bowel urinary or other symptoms. She had presented on different occasions in the last 4 years with similar symptoms at the tertiary health center. On examination, the patient was conscious with a Glasgow coma scale of 11/15, and she had some respiratory distress, severely pale, febrile, and ecteric with low pedal edema. The pulse rate was 107 beats per minute, and blood pressure was 1640 millimeters of mercury. Respiratory rate was 32 cycles per minute with oxygen saturation of 87 in room air. The abdomen was flat and soft with no pathological organ or masses. Pelvic examination revealed a polypoid mass with septic and necrotic spots within the vaginal cavity of approximately 12 centimeters in diameter, with bleeding from septic and necrotic areas in the mass. Sonography showed a normal size with normal agnesia. Blood test done also revealed a hemoglobin of 1.7 grams per dl and the hematocrit of 6%. Electrolyte, urea, and creatinine values were within reference. Her blood group was O D positive, and the hemoglobin genotype was AA. She was admitted at Backwell Medical Center, a private secondary care facility. Management, patient declined having blood transfusion, providing a durable power of attorney documentation to support her decision. Now, based on this, the multidisciplinary body medicine and surgery team was invited to join in our management. It was conservatively managed with bed rest, hydration, analgesic, anti-malarials following a positive blood smear, erythropoietin, tranexamic acid, vitamin K1, intravenous iron, danazole, and oxygen by face mask. In the first week of admission, she continued to bleed vaginal, albeit slowly, persistently. We dipped her hematocrit to 0.9%. Attempts were made to refer her to a tertiary health center, and her relatives declined and opted for continued treatment without blood transfusion. The conservative management resulted in cessation of bleeding and a significant relief of all symptoms. Hemoglobin began to rise progressively. Week 1, she got to 3.7 grams per dl. Second week, she had 5.0 grams per dl, and in week 3, she had 8 grams per dl. She had a polypectomy done with pressurization of the base. Needed blood loss was 600 mils without homologous or homologous, no blood or blood fracture transfusion pre, intra, or post-operative. Immediate post-operative hemoglobin was 7.5 grams per dl. Her recovery was uneventful, and she was discharged on the 7th day post-op. The study report on the polyp showed leiomyoma with areas of inflammatory cell and thickened wall of congested vessels with hemorrhagic areas and no evidence of malignancy. Diagnosis of leiomyoma could be follow-up visit at 6 weeks, post of the base of the polyp with normal re-energization. Hemoglobin was 11.5 grams per dl. Patient had fully recovered, having normal menstrual cycles, and had since resumed work. The discussion. Anemia may be present in as much as 80% of presenting with heavy menstrual bleeding. Anemia from heavy menstrual bleeding is complicated by iron deficiency, as women with heavy menstrual bleeding are reported to lose an average of 5 to 6 times more iron per cycle than women with normal blood loss. This is because more than 2/3 of the body's iron is bound to hemoglobin molecules in both mature and electrolytes. Precursors. Hemorrhage from any source will invariably lead to a loss of hemoglobin and iron, and this in turn will impair the synthesis of new red blood cells, leading to a vicious cycle. This mechanism probably played a significant role in the development of life-threatening anemia in our index patient who has had heavy menstrual bleeding for a particular period of time, up to 4 years. The patient had presented with a very low hemoglobin of 1.7 grams per dl, which quickly deteriorated even further to a PCB of 0.9%. due to ongoing bleeding and probably underlying iron deficiency. Anemia of less than 6.5 grams per DL is graded as life-threatening by the National Cancer Institute. This was therefore not expected. It was therefore not expected that our patient will be alive without an extremely low hemoglobin. Some guidelines on the management of menstrual bleeding due to high risk anemia recommend the use of blood transfusion at hemoglobin less than 6 grams per DL in symptomatic patients and 5 grams per DL in those who are asymptomatic. A second guideline noted that the decision to transfuse should be not based solely on the hemoglobin level, but that hemodynamic indices should be considered, since some individuals can tolerate anemia up to hemoglobin of less than 7 grams per DL. These recommendations on the hemoglobin threshold for transfusion may need to be revised in current evidence. This case has demonstrated, in conclusion, this case has demonstrated that the human body can tolerate much lower hemoglobin values than may have been expected. Life-threatening anemia from heavy menstrual bleeding can be corrected in a few weeks without use of allogenic blood transfusion. In 3 weeks, hemoglobin can be raised from less than 1.7 grams per DL to 8.5 per DL using alternative blood transfusion like iron and erythropoietin. Iron deficiency from heavy menstrual bleeding should be mitigated by oral iron therapy in all women of reproductive age who are diagnosed with heavy menstrual bleeding. Finally, heavy menstrual bleeding will be carefully evaluated, followed by prompt interventions, including surgery, if necessary, in the actively bleeding patient who refuse blood transfusion. These are my references. Thank you very much.
Hi, Kenneth. Thanks for a very nice presentation. One of the questions, obviously, very well managed in an acute setting with the solo hemoglobin. From a just national perspective, do you screen routinely for people with low hemoglobin in Nigeria? So if you have reproductive age group, and if they found to have anemia, is there any government policy or hospital policy to increase their hemoglobin in that age group?
Not necessarily. I think what we know is that all pregnant women are screened for anemia, and then they are optimized with oral iron. That is the policy. That's the practice. But for heavy menstrual bleeding until it becomes symptomatic and they present, there is no active phase surveillance.
Okay. And any of the panelists have any questions to ask her at all, or ask Dr. Kenneth?
Hi, I do have a question. Thank you, Dr. Naku. I did wind up answering a bit of this question before for another question asker in our Q&A section, but I wonder, with that remarkable example of such a low hemoglobin, how do you calm the waters, so to speak, among your colleagues when they want to do things like frequent lab testing to watch that low hemoglobin, which therefore causes more anemia, as opposed to getting everyone to pay more attention to the patient's presentation, signs and symptoms, and not worsen the anemia they're facing?
Yes, we do practice microsampling too. In fact, for such a patient, we conduct lab tests that are just the very important ones. And if there is usually a point of care testing where we can estimate the hemoglobin at bedside. So you don't need a few drops of blood. And if we are doing a PCV, just the heparin strains, very, very tiny. In fact, it can hold about 0.1 bits of blood. So all that would lessen the amount of blood that we lost for investigations.
Yes. So in our bloodless unit, we have HemoQ, which we use to check the hemoglobin.
Okay. So now, thank you, Dr. Kenneth. I think stay on the panel so if more questions pop up. So now I'll pass it on to Animi to just introduce the third and the fourth abstract speakers, please.
Okay, good afternoon. The third presenter here is Abigail Ivara. She is a nurse and she'll be presenting on the topic Nursing Informatics in Bloodless Care. Abigail, you're welcome.
Thank you so very much, ma'am. I appreciate. And as introduced, I want to share my slide. Okay, assuming my slide is very visible, right? I can go ahead. Nursing Informatics, Bloodless Care, as introduced. Introduction. Nurses have always been at the forefront of patient care and therefore often feel the impact of changes in best practices immediately than other healthcare professionals. This cannot be disputed. Nursing informatics refers to technological tools, systems and practices that nurses use within the clinical workflow or in leadership roles. Medical informatics is used as an all-inclusive term both to describe any informatics efforts related to healthcare and also to describe a distinct specialty in the discipline of nursing. The ability to deliver safe, competent treatment in a highly technical and digital setting is demanded of healthcare practitioners. Bloodless care is also largely about patient safety and improved outcomes, as well as protecting patients' rights. An understanding of how each type of system works within the healthcare organizations is fundamental to promoting the quality of healthcare, improving data handling and the patients. The aim of our study was to find out ways that the implementation of nursing informatics could help to improve the quality of bloodless care. Methodology, we carried out a review of the current literature on nursing informatics in Google Scholar and PubMed to identify its implication in bloodless care. Now, I want to know the definition of nursing informatics. According to the Canadian Thesis Journal of 2024, defines nursing informatics as the practice and science of integrating nursing information and knowledge with technology to manage and integrate health information with the goal to improving the health of people and the communities while reducing costs. The American Nurses Association of 2023 defines nursing informatics as the integration of nursing science, computer science, and information science to manage and communicate data, information, knowledge, and wisdom in nursing practice. Continuation of definition according to Material 2024, it defines nursing informatics as a specialty field that integrates theoretical nursing knowledge with informational sciences and analytical processes to critically examine and accurately interpret clinical data, streamline clinical workflows, and improve patient outcomes. Davis et al. Also define nursing informatics as the application of information technology in the nursing responsibilities encompassing management, practice, and education. According to Cherry, implementing nursing informatics systems provide better access to treatment, which positively affects patients' care quality and augments evidence-based nursing. What are the historical origins of nursing informatics? Nursing informatics dates back to the 1950s with the emergence of the first computer. We have about the first, second, third, up to the fifth generation of computer. But since from the first generation, nursing informatics started. So, and this was from our founding mother, Florence Nightingale. She's the first informatic nurse. And she's a nurse that is teacher who contributed in collecting, organizing, processed, and distributed patient data during the Crimean War. I'm sure most of us are very much aware of that. With advancement of computer and information technologies, there's been growing demand and need for improvement in nursing informatics, and its use in many disciplines in health systems, including bloodless care. These are just to address also the various parts that we use for information system, that's the computer. And in 1982, in the United States of America, a capital round table of nursing informatics was carried out, known as a not-profit organization. And that was funded by a group of nurses who focused on advancing automated healthcare information system. And another advancement in nursing informatics was the successful publishing of the first journal of nursing informatics in 1983. The journal was called Computer in Nursing, or CARI. And subsequently in 1992, 2010 till date, there's been several advancements in nursing informatics used in delivering quality, evidence-based care of our patients. Importance of nursing informatics cannot be overestimated, as nursing as a profession is vitally important and highly demanding. A career in this special field means routinely working long hours on the front lines in hospitals. This can be seen during the COVID-19. And long-term care facilities such as homes, completing a wide range of complex tasks with potentially life-threatening cases. This cannot be underestimated. Informatics in nursing offers powerful resources to help meet these responsibilities and improve standard of care, according to Adult 2024. According to Majarillo 2024, some of the most promising effects from the advent of informatics-driven strategies in nursing include superior patient outcomes, more efficient clinical processes, more collaborative and coordinated care, and advances in telehealth. Informatics applications plays a crucial role in nursing in the field of education. Other notable importance are performing diagnostics procedures, which is very necessary in bloodless care, developing care plan with the aid of 11 Gordon functional health pattern, and this was propounded by Dr. Majori, and using the acronym IPPA, which is inspection, percussion, palpation, and auscultation. And we evaluate this on our patient using some of the criteria like evaluating their nutritional values, trying to see their coping mechanism, and also going further to see their elimination pattern. Minimization of nursing and medical errors, that's another importance. Efficiency of care services, educating patients and their families on informed choice, such as bloodless care. We carry the patients along and their families. Nursing informatics can be used to assess an unprecedented volume of quantitative information to meet the needs of patients more accurately. With such information, nurses can develop important reports that can be shared with other clinicians to improve patients' outcomes. We don't work in isolation. Nursing informatics aims to use data-driven approaches to nursing that will improve healthcare quality and drivers for research and integration of more advanced technologies to enhance the clinical experience for both providers and patients. According to Pascal et al. 2011, he conducted a study to investigate how integrating the e-health records system will provide more value to specific patients and population for chronic diseases. A quantitative research design was employed using a time series analysis of significant internal nurses with experience on e-health record tools. The findings indicated that electronic health records significantly improved nurses' performance and good patients' outcome. Moreover, it was noted that informatics promotes patient-centered healthcare, educates patients and health professionals, identify patients who are at higher risk for serious conditions, and take preventive steps early. Application of nursing informatics to bloodless care. Bloodless care refers to an improved patient's outcome with the use of clinical strategies for their medical and surgical procedures without the use of allogenic blood. Nurses, as active frontliners of healthcare, should remain informed of the latest clinical evidence-based treatment to bloodless medicine and surgery. Applying knowledge of nursing informatics will help nurses to be more observant and proactive in patients' care, especially those just like my co-presenters just stated, so as to save lives. Nurses are empowered to take ownership of patients. Nursing informatics will also enable them to be extra vigilant in evaluating and reporting loss of blood and patient's coping mechanism of anemia. It also will help in establishing effective communication among the multidisciplinary team to providing the best care and possible patient's outcome. It also helps to preserve patient's information by not sharing them with those who are not really necessary to know about patient's information. It offers holistic care to all patients. Nothing Informatics also aids research in bloodless care, education related to specific documentation, education related to patients' informed choice. You allow them to make their informed choice whether they want blood or not. Promotion of quality and evidence-based care. It helps to analyze patient data and offer useful information like clinical guidelines. It also helps in care coordination of bloodless patients. Conclusion. Nursing informatics is an essential and expanding component of medical services. The benefits of e-health records, that's electronic health records, are numerous for both patients and medical professionals. This application to bloodless care reduces medical blunders, enhances efficiency, time management, effective communication, promote patient-nurse relationship, and facilitate quality healthcare delivery based on evidence. Thanks for listening, and those are my references.
Yeah, thank you. Thank you for staying within your time. I have checked, I've not seen any questions for her, but if you have any question, you can raise up your hand, you can ask. The floor is now open. It's time for questioning.
Okay.
Do we have any questions? Okay. Can we move to the next presenter?
I'm afraid it looks like the next presenter has gone off. That is Dr.
George.
George, yeah. George Eleje. He was here a while ago. Maybe his network is off.
Okay.
So if there are any discussions, could be discussed.
So Nathaniel, there was one interesting question about using cell savers in cancer surgery. I think me and Morton were having a discussion. I was wondering if any other panelists or have any experience of this in your particular country or institution?
Please say that again, probably.
And Morton had put a question on the panel saying that the use of cell savers in cancer surgery. Usually there was a theory that you may transmit cancer through cell saver mechanisms or use it. So we had an interesting discussion about it. I thought we don't use it anymore in our practice, but we were just wanting to see if any other panelists have any ideas about who use cell savers. Has it been in any other cases apart from trauma surgery, especially in cancer surgery?
Transferable.
So our conference chair, Dr. Waters, unfortunately, he's not able to be here, but he has done a lot of work on cell salvage, and he has published much to show that there is actually no danger in using cell salvage in cancer. And I think he's not the only one. There have been other publications. Tomorrow we're going to have Dr. Selby. Dr. Selby, who is a professor of surgery in California. So he'll be talking tomorrow, and I think he'll probably address that question as well. So I think we should ask him again tomorrow And I think by then we can also provide some references to show that it can be used quite safely.
Okay.
You see, the cell salvage filter itself is designed to filter to withhold any big cells. It's only the red cells.
Yeah.
And the cancer cells are bigger than red cells, really. So they are actually held back. They're not put back into the patient.
Okay. But usually in my practice in UK, Singapore, and in India as well, usually we don't encounter such blood losses at all. So modern surgery is so safe. We hardly have 100 mils of blood loss. You are a surgeon yourself, so we never even ask for cell savers in theater at all. So it's interesting point for discussion, though, in case you need it. So, okay.
Yeah. Probably it doesn't have to do with the geography. It just means that you're a good surgeon.
Kind words, but
Dr. Frank is still around. I don't know whether he had any comment on that. Steve, do you have any comment? Is he around? Okay, it looks like.
maybe we address tomorrow again. I think that will be a good
Yes,
point
I believe so. Yeah.
discussion tomorrow. So I think if Prof. George is not there, I think we may end the session. I think thank you to all the speakers who have taken time out to present very interesting topics, and we continue our pursuit of achieving excellence in bloodless medicine and surgery, and showcasing case reports and nursing initiatives and further programs. So I would could I kindly request all the speakers to come on put the video on. So I think Nathaniel wants to have a group video or a group photo for the session. If I all could switch on their video and then show a smile for the photograph, and then Nathaniel will kindly.
Yes, please. Everybody turn on your video. Doesn't have to be only every single person who is on the panel should please turn on their video. And I'm not going to be the only photographer. All of us should see if we can turn on the gallery view. And so that everybody is gallery, right? So now, Abigail, we can't see you. And Heather, Mandy, Dave
Yes,
is not
I
around.
am.
Oh, great.
Here. Can you see me now?
We can't take a picture without you, Mandy. I think Steve is busy. Dr.
Yeah.
Yakubu?
Can you see me?
Yes, I can see you, Mandy.
I'm here. Nathaniel?
Yes, Mandy, can you hear me? I can see you.
Yes, I'm here. Yes, I can. I can hear you. I'm here all the time. Yeah, just behind the
you, sir. Dr. Yewo.
Okay.
And Heather is not around. Steve, okay, I think, so let's all of us take screen grab. And please, everybody should smile. Oh, I forgot to turn on my own video. Yeah, let me turn on my video. I'm not very photogenic, so that's why I forgot.
We'll manage.
Thank you. I'll do that again. Okay, everybody, please smile. Okay. I think I am okay. Has everybody taken?
Check again.
Okay. Abigail, did you say you want to take again or you want me to take again?
You take again. I've done mine.
Oh, okay. So please touch your smile. Make sure it stays in place. Yeah, I got it. Thank you.
Thank
Back to you,
Thank
Prabhu. Yeah.
So, I said, thanks everyone. So that was a great session tonight. Nathan, do you want to just preview the session for tomorrow? I don't have the program for that.
Oh, I'm sorry. Okay, I'll turn on I will share the program.
Yeah, that'll be
Just a
great.
minute. Oh, Schneider, do you have the program on hand? So even if it doesn't, mine is coming up in 2 seconds. Okay, so I'm trying to share my screen now.
Okay.
Let me see. Let's see. Is it coming up? Can you see anything?
Yeah, we can see the
cover.
Yeah, I think you just need to go down
So
to.
let me see which direction I'm supposed to scroll on. Let me see.
Yeah, there you go. One more.
Can you see?
Yeah.
All right. So you can go ahead and preview it.
Okay, so tomorrow morning, obviously look at your local timings when to log on. I think the first session in the conference will be the My PBM session, Pillars of Bloodless Medicine. There's a keynote address by EYAP from Malaysia about raising the hematocrit without blood transfusion evidence-based, followed by Van Faisem, who's going to talk about minimizing blood loss at surgery to improve oncological and functional outcomes in musculoskeletal tumor, also from Malaysia. Third, again, a similar talk from Malaysia would be about optimizing tissue oxygenation and supporting patients' tolerance of anemia perioperatively. So it'll not be interesting to see the Malaysian discussions in the morning. And following this would be the bloodless surgery techniques, with the keynote address being the bloodless surgery improves outcome in cardiac surgery by Professor Peter Knight from Rochester. Preoperative techniques in bloodless surgery, a reflection at BAIT. So anyone who's interested in surgical techniques would be a good one to join Saidu Yakubu from Nigeria. And the last would be, which obviously me and Nathan are having a discussion about, oncology and transplantation surgery without blood transfusion, why and how. So Robert Selby, Professor Surgery from Los Angeles. So that'll be very interesting discussions tomorrow. So hopefully we'll see you all back tomorrow and then enjoy the journey as we go along.
Thank you very much.
Okay. Thank you all and have a good night.
Bye-bye.
Bye.
Good morning.
Thank you
Bye,
all.
everyone. Thanks.
Great first day.
Bye. Bye.
So Schneider, you are the host. You can end it.